Hello, everyone. Welcome to the 2020 Hep B United Virtual Summit. My name is Kate Morars. I'm the Deputy Director of Public Health at the Hepatitis B Foundation and Director of Hep B United. Thank you so much for being here. This year marks Hep B United's 8th annual summit and first virtual. As much as we would have liked to reunite in person in Atlanta and give each other hugs, we're so excited and grateful for the opportunity to convene safely in this virtual space. We're also happy to include many more partners than we would have been able to in person. And for those joining us for the first time, I'd like to take a moment and share a brief introduction to the Hep B United Coalition. Launched in 2011 as a national coalition co-chaired by the Hepatitis B Foundation and APCHO, we came together as a forum for community organizations across the United States working on hepatitis B education, testing, vaccination, and linkage to care programs to share best practices, resources, and exchange ideas for improved local capacity to address hepatitis B. Our goals focus on awareness, prevention, and intervention to increase access to treatment and prevent liver cancer. Our coalition partners now number nearly 50, comprised of national organizations and community-based hepatitis B coalitions. We represent 22 states and 29 cities with over 1,000 community partners in our local networks. And as a reminder of our value statement, more important today than ever, we're a national coalition comprised of advocates, community leaders, and stakeholders that focuses on the health equity, respect, and empowerment of those affected by hepatitis B. Utilizing evidence-based public health best practice, we promote equitable access to healthcare, preventive services, preventive medicine, testing, linkage to care, and treatment for all communities at risk for hepatitis B. And we strive to ensure our values are reflected not only through our coalition's work every day, but throughout the summit as well. This year's theme is Standing Up for Hepatitis B, creative collaborations to amplify awareness, access, and equity. And we know we have to be especially creative this year. So what can you expect over the next 3 days? We're excited to kick things off with sessions today around the theme of amplifying the patient voice or those with lived experiences. We'll start off shortly with an important introductory discussion on how bias and racism affect healthcare. Then tomorrow and Friday, we'll hear from federal partners, state and local health departments, and community partners on programs towards the elimination of hepatitis B. And we'll wrap up this year's summit with a celebration reception to recognize this year's Hep B champions. You'll hear more details on the agenda in a few minutes from Sherry Cohen, our coalition co-chair. But before we hear from Sherry and Jeff, I'd like to point out some resources in our virtual conference space. In the top left menu bar, when you go back to the summit homepage, you'll see a host of amenities and ways to participate in the summit. So be sure to visit the exhibition hall and meet our sponsors. And if you haven't already attended the poster session earlier, check out the presentations anytime in the poster gallery. In the attendees tab, take a look at who else is here and even send direct messages and request a video chat. In the documents tab, you'll find copies of the presentations and other handouts. And most importantly, please have fun. We've set up a virtual scavenger hunt within the summit. Join in on the friendly competition, and you'll find that in the gamification tab. And don't forget to share your experience on social media with the hashtag HepBUnite2020. You can also see the latest tweets and Instagram posts on the social wall. And finally, I want to say a special, very much thank you to our Summit Planning Committee for putting together a wonderful program. I also want to thank the Hepatitis B Foundation staff and a very special shout out to Beatrice Sovich, who ensured all the details came together smoothly for our 3-day summit. And she is right now running the show behind the scenes right at this moment. And thank you everyone again for being with us this week and the important work you all are doing to eliminate hepatitis B.
We are very happy to welcome you to the 8th annual Hep B United Summit. It looks a little bit different than it has in years past. It's not July for one thing. We can't all go to Shake Shack tonight when the sessions end, but we are together. And I am grateful that we are able to spend the next few days with each other. Each year, we bring together partners from around the US to share best practices towards eliminating hepatitis B among high-risk communities. This is our chance to discuss strategies, troubleshoot challenges, further our partnerships, and unite our voice. This year, our Hep B United Summit theme is Standing Up for Hepatitis B, creative collaboration to amplify awareness, access, and equity. Day 1, today, focuses on amplifying the patient voice and lived experiences of hepatitis B. We will hear about recent efforts to document the thoughts and experiences of people living with hepatitis B, and our Just B storytellers will lead us in a discussion about how people living with hepatitis B can become educators and advocates. We will also hear the latest updates in hepatitis B cure research. Day 2 focuses on collaborations to eliminate hepatitis B. We will hear from our federal partners at HHS and CDC and have a chance to ask them questions about current and future plans. Community partners will share strategies for changing hepatitis B education and screening programs during the COVID-19 pandemic. And we will have breakout sessions focusing on improving adult hepatitis B vaccine coverage in the US and building integrated, comprehensive state elimination plans. Day 3 focuses on collaborations to amplify access and equity. We will have a session on working with non-traditional partners for improving testing and care, which is a topic partners have been asking for at least a few years. We will end our Hep B United working sessions with an important discussion exploring the ways that structural and institutionalized racism have impacted healthcare and health status for minority communities in the US. We hope that this discussion will help us as a group and individually to become more aware of unconscious bias and stereotypes and what our roles can and should be in addressing racism and bias as we work towards equity for our partners and for the Asian American, Native Hawaiian, Pacific Islander, and African communities that we serve. Finally, we will wrap up with our annual award ceremony and reception, honoring outstanding individuals and organizations around the US committed to addressing hepatitis B in their local communities. We will be conferring a special Federal Champion Award to Karina Dan for her years of dedication to addressing hepatitis B and for standing up for the 2.2 million people infected with hepatitis B during her time at HHS. Don't forget all the ways we have to engage with each other throughout the summit. There are posters and partner videos. You can visit our sponsors in the exhibit hall for live chats. We have games, contests, a social media wall, and special areas just for connecting with partners. And I'm sure Oliver is going to make another appearance. We welcome you to use all of these ways to engage with each other, and we hope that they add a little bit of fun to our 2020 summit. I would like to thank the Hepatitis B Foundation Public Health team for working so hard to plan this year's virtual summit. Thanks to Michaela, Catherine, Rhea, Evangeline, Yasmin, Ed, and Maureen. Special thanks to Beatrice for taking on all of the technical details and building out the platform. And of course, thank you to Kate, our Hep B United and Summit leader. I would like to thank our Hep B United Summit committee as well for helping to put together an engaging and important agenda. I always walk away from our summit awed by the work that partners are doing and with renewed energy to go out and make a difference myself. I know that every person in this room has been struggling this year and pushing forward to find new and innovative ways to meet the needs of our communities as they too struggle. I look forward to learning about these efforts and to becoming re-energized through spending time together. For now, I welcome you and I invite you to enjoy your time at the 2020 Hep B United Summit.
Welcome. I'm Jeff Caballero and I want to welcome you to our 8th annual convening. I must admit I regret not being able to convene and seeing you all in person, but I am glad that we are able to still meet even virtually. For this convening, I first must ask we all recognize the hardworking staff of the Hepatitis B Foundation and the planning committee members. Then I must also express my gratitude to you all as participants. To me, your ongoing participation to our annual summit represents the core of the hepatitis B movement. Your stalwart commitment to our community and to service is central to our resilience and fortitude as a community. It's inspirational, particularly during these trying times. Our communities coming together for the summit is well represented by our theme, Standing Up for Hepatitis B, creative collaborations to amplify awareness, access, and equity. And we must stand together for the challenges we have encountered and the challenges we have ahead. We have all seen how hepatitis B screening, vaccination, and treatment services have been reduced across the country, as well as our community providers had been impacted in unbelievable ways. For those of you who don't know, in the community health centers space, hundreds of health centers have had to close down, and many thousands of staff had to have been furloughed. And also for our most vulnerable, the Asian American and Pacific Islander communities across the country. The vulnerable population to hepatitis B, particularly those in poverty and with limited English efficiency, are also some of the most vulnerable to COVID-19. We are learning the essential workers and agricultural workers vital to picking, delivering, and selling our essential foods and services have inadequate access to screening services and healthcare. And last year, I remember speaking to you about public charge and how that was a threat to our efforts to reach the vulnerable. As if COVID was not enough, the political administration stepped up its rhetoric, repeatedly framing the coronavirus as the China virus or the Kung flu. We believe this rhetoric was very harmful, contributing to over 2,700 incidents of documented discrimination against Asian Americans throughout this country. Needless to say, it should be clear why our most vulnerable are overcome, not just by the COVID pandemic or our economic crisis, but also the related discrimination. I have hope though. I have seen what our communities can do. We have just seen the greatest mobilization of Americans to have ever participated in an election. The momentum is with advocates who believe in a government based on compassion and justice. And we need this to rise above our challenges. Advocacy must not stop. Telemedicine has helped by expanding services and access, but it is not enough. It is just part of the answer. Advocacy for resources for you as a trusted community messenger and healthcare provider must continue and increase. Then, before us, it lies the biggest public health opportunity, the COVID-19 vaccine response. To quote a colleague of ours, Dr. Rita Kuwahara, we are about to embark on one of the largest mass public health endeavors in history. What does this opportunity mean? That means if we are to be successful, we will witness the greatest political and financial commitment to develop the systems and infrastructure necessary to administer this multi-dose vaccine, and also establish the outreach and communication efforts between every patient and their most trusted messengers like yourself. This is so important. Let me repeat it. While we are preparing for the mass COVID-19 vaccination efforts, let's make sure that the people most vulnerable to getting hepatitis B also receive their COVID-19 vaccine. Our advocacy must not waver during this critical period. Let us also examine how the system and infrastructure developed to deliver the COVID vaccine can be leveraged and sustained for the elimination of viral hepatitis, particularly the prevention of hepatitis B. If you are wondering if we can do this, you must all agree the answer is before us. Yes, we can, and yes, we will. Thank you very much, and I look forward to getting to know you better throughout the conference. Goodbye.
Hi, everyone. So great to see everyone here today. Like I said earlier, I really miss seeing everyone in person and giving us virtual hugs, but we're all safe, and that's all that matters. I want to thank Sherry and Jeff for their inspirational words and for their leadership in leading the coalition since the beginning. Before we jump into our sessions today, I'd like to keep up with a Hep B United Summit tradition and to get to know one another a little better. So if you haven't had a chance yet to introduce yourselves in the chat box, please do so. Say hi, where you're from, what organization you represent. But I wanted to start off with a quick icebreaker. So if you remember when you first registered for the summit, we asked you to answer a few questions. So they were, how long have you been working in the hepatitis B field? How long have you been a member of Hep B United? Name an interesting fact about your city or state and what's outside your window. So on this next slide, we compiled all of the registration information and wanted to share that with everyone now. So it looks like everyone's been working in the Hep B field for an average of a little over 7 years. And one person has even been in the field for 40 years, which is amazing. So if you're here online right now, who is that? Feel free to type that into the chat box. And if you didn't get a chance to answer this question during the registration, feel free to type your response in the chat box now. And then on the next slide, our next question was, how long have you been a member of Hep B United? And I'm just waiting for the slide to pull up. Oh. Okay. Sorry, I think there might just be a delay on it. Oh, there we go. So it looks like 4 years on average, and 5 people since the beginning. So who are those 5 people, I'm wondering? Feel free to type that in as well. And also, again, if you didn't get a chance to answer yet, feel free to type your response in the chat box now. Great. So I'm just seeing the chat here. Looks like we have a range of years working in the hepatitis field. Awesome. Thanks, everyone, for joining in. Oh, Bob Fish, 30 years. Wow. Awesome. All right. And then on the next slide, name an interesting fact about your city or state. Spray paint was invented in Chicago, which is cool. The internet was invented in Arlington, Virginia. That wasn't for me, but I am currently in Arlington, Virginia, and yep, that's right. What else? Hawaii consumes over 7 million cans of Spam per year. We love our Spam musubis. New York City has one of the first dedicated programs working with the eradication of Hep B. Go New York City. And Vancouver has been ranked, so we have a Canadian in the house. Vancouver has been ranked the 3rd most livable place in the world. Awesome. All right, yeah, and again, if you didn't have a chance to share an interesting fact about your city or state, feel free to put that into the chat box now. Washington State is ranked #2 in the nation to receive refugee arrivals. That is amazing. All right. And then finally, on the next slide, since we can't be together, let's all take a snapshot of the view outside your window and post it in the activity feed. So if you're looking for the activity feed, that's in the left-hand navigation menu, and you'll see the 3 bars in the top left of your screen, and you'll see all the options there. So when you get a chance, let's take a look at what we're all looking at outside together, and get the activity feed going as well. Awesome. I'm still looking at the chat, and it looks like the East Coast gets more rain than Seattle. I'm sure that's a surprising fact too. All right, great. Thanks again, everyone, for participating in the chat. So before I close out our icebreaker, and head into our first session, I do have one more housekeeping item. If we were together, this is where I usually point out where the restrooms are, but instead, I'll just point out where our help desk is, our online help desk. So if you need help with, say, your audio is not working, or you can't see the video, live support is available from Event Movies. So you can just go to the bottom of the left-hand menu and select the live support option, and then someone will be with you shortly and help answer any questions that you may have. As for non-technical issues about the summit and its program or the agenda, when things are happening, where to find posters, things like that, feel free to click on the Ask the Organizer tab on the left side menu, and you'll be in touch with Beatrice Zovich, and she will get right to you. All right. I am now very excited for our next session on bias and racism affect healthcare, invitation for reflection. But to properly introduce the session and set the stage, please welcome our moderator, Chioma Naji, who is the program director of the Multicultural AIDS Coalition and a culture of health leader with the Robert Wood Johnson Foundation. Thanks so much again. Great to see everyone.
Good afternoon, everybody. Thanks to Hepatitis B United and partners for having me and convening this amazing summit. I've attended this summit for the past 3 years, and today I'm honored to be a part of the program. Again, my name is Chioma Naji. I'm a program director at the Multicultural AIDS Coalition in Boston, Massachusetts. I welcome you to this session on how bias and racism affects healthcare and invitation for reflection. The organizers of the summit were intentional on having an introduction to lay the groundwork for our longer conversation that will be happening on Friday at 2 p.m. Eastern Standard Time. So I'm hoping that you plan to attend that so we can continue this conversation. As many of you already know, there's a lot that can be said about this year, 2020. It has been heavy for many of us. Definitely for me, it has brought on a wide range of emotions, sadness, joy, anger, anxiety, and at times relief. One thing that can be consistently said about 2020 is the unwavering racial inequities that we have been seeing, particularly the lived experiences of Black communities and other people of color. Through the ongoing high-profile state-sanctioned violence and killings of Black bodies, the racial inequities that we're seeing in COVID-19 testing, treatment, and deaths, and the criminalization of Black and Brown immigrant communities through anti-immigrant policies and rhetorics, we know that bias and racism is operating at many levels in our institutions, in our systems, and overall in our society. Racism in America is not new. I know many of you already know that. The impacts of racism on health, including hepatitis B treatment and outcomes, is not new. I know you also know that. While race is a social construct with no real biological basis, it is embedded in the story of America, a story that reinforces and normalizes the oppression of Black, Indigenous, and people of color communities. One of my favorite quotes is from Dr. Ibram Kendi. He is an author, a professor, and an anti-racist activist. He says the only way to undo racism is to constantly, consistently identify and describe it. And then, and only then, are we able to dismantle it. So for today, our time together and our time on Friday will allow us to self-reflect and also think about the environments in which we work and the communities that we serve that are highly impacted by racism, bias, and other forms of oppression. I'm excited to be in this space with you and engage in critical dialogue. We have Dr. Bernard Lopez, who will lead us on this journey. Dr. Lopez is a professor and executive vice chair in the Department of Emergency Medicine at the Sidney Kimmel Medical School of Thomas Jefferson University in Pennsylvania. He received his doctorate in medicine from the Sidney Kimmel Medical School in 1986. He completed a residency training program in emergency medicine at Thomas Jefferson University Hospital in 1989. Since 2013, Dr. Lopez has served as the Associate Dean for Diversity and Community Engagement in the medical school, providing oversight of diversity and inclusion initiatives for faculty, graduate medical education, and medical students. In January 2017, he added the title of Associate Provost for Diversity and Inclusion at Thomas Jefferson University. And now I would like to welcome Dr. Bernard Lopez.
Great. Chelma, thanks for that. Actually, not just my introduction. The introduction to me, not as important as the introduction that you gave to this whole topic. Very wonderfully done, and it just leads into the topics that I'm going to touch on. So I just want to say I'm really pleased to be with all of you today. It's for me, it's so cool that I get to talk with people from all across the country. And I'm hearing Hawaii in this, so across all time zones, but just really a pleasure to be able to be with you, be with you for 30 minutes or so today, but to be with you for a longer time on Friday where we can really dive into these particular topics. So think of this first session as an introduction to. I'm going to have a little call to action at the end for you here, but this is just the beginning of this longer conversation that we will have during this particular conference. So with that, I'm going to speak with you today about unconscious bias, race, and racism. These are things that live with us. They live with us on a daily basis. We don't even really realize that they exist, at least in our interpersonal interactions, yet they're there and they affect our decision making, they affect our relationships. All right, so if we could have the video.
Hospedeira, arranje-me outro lugar.
Minha senhora, a classe económica está lotada.
Desculpe, eu não vou viajar ao lado do negro. Faça qualquer coisa.
Eu vou falar com o comandante. O comandante manda dizer que conseguimos arranjar lugar na primeira classe. E pede imensas desculpas. Realmente é inconcebível um passageiro viajar ao lado de uma pessoa tão desprezível. O senhor acompanhe, por favor?
So often, when we hear the word bias, we hear the word unconscious bias. That might be something that comes to mind. Well, clearly that's not unconscious bias. That's overt bias. That's overt racism. Yet this is often what we think of when we hear those words. Now, hopefully most of us don't live in these situations on an ongoing, regular basis. In reality, we live with bias on what's called an everyday basis. So I have no conflict of interest. There's a book out there. So Howard Ross runs a company called Cook Ross Incorporated. He's written a number of books on this topic. This happens to be one of my favorite books. So I've learned at least the foundation of unconscious bias and microaggression through Howard Ross. But he wrote a book called Everyday Bias. So really, this is something that we live with on a regular and unconscious basis. This book, I'm hoping that you get interested in this topic. It goes into the science behind unconscious bias and really shows real life examples of how bias exists, how unconscious bias exists in our everyday lives and how it functions. So here's a simple definition of bias, unconscious bias. So bias is a tendency or an inclination that results in judgment without question. All right, so just in that video that we saw, often we think of bias in a negative way. I'm biased against something. Well, the reality of it is you can be biased towards something. It can be positive, it can be negative. So this is simply a neutral definition, a tendency or an inclination that results in judgment without question. And our unconscious biases really allow us to function without a whole lot of thought. Fortunately, the majority of the time it serves us well. Okay, so you're walking, it's late at night, you're on a dark, lonely street, you come across a figure that looks like this. Right? So what do? Well, most of us have a bias. Hopefully all of us have a bias against something that looks like this. We react very quickly. Typically we'll turn, we'll run. I've heard people say, they scream, but typically we would react very quickly to this to move us away from this particular view, this particular object. It's not likely that any of us would say, you know what, I'm going to be scientific in this. Let me find out more information before I go into action. How many degrees does this person have? Who could this be? Maybe that sharp-looking object is really not something dangerous. Well, none of us would do that. If we were to do that, we'd not likely be around to make another decision. So this bias that we have against something that looks like this really serves to protect us from harm. So unconscious bias is built into us. It's part of who we are as human beings. And it really serves to protect us from harm. Right? Again, hopefully we're not in these situations where we're constantly in this sort of harm. So our biases then really function in our everyday lives. It allows us to move forward without a whole lot of thought. I'm going to get just a couple examples of how bias can work, unconscious bias, how it can work. So here, a resume, a curriculum vitae, a job application, an educational application. So if you think of what those are really just collections. They're collections of accomplishments and achievements. Well, based upon our biases, the name that's at the top of that resume or that application has great effect on how that set of accomplishments and achievements are viewed, right? So same set of accomplishments and achievements, how it's viewed depends on the name that's at the top. So we see the studies in the United States. Well, we see studies all across the world that show that this happens, the impact of a name. So this isn't a United States phenomenon. This is actually a worldwide phenomenon. It's really a human phenomenon. You know, I speak much to healthcare providers, physicians, nurses. I do lots of talking with healthcare providers about unconscious bias. So I ask our physicians, are we biased against our patients? Well, hopefully not overtly so, but unconsciously, yeah, because we all have our biases. So I speak for my profession, we as physicians, we're biased against our patients, granted, unconsciously biased. But what makes this whole thing complicated is our patients are biased against us. So when I talk about complex medical situations, and you can really extrapolate this to really any complex interactions in any field, you take that complex situation and then you overlay on top of that my bias, the patient's bias against me. You can imagine that you've just taken that complex environment, that complex situation to a whole nother level. So here's my favorite study when looking at bias. All right, so here's a study. This was done looking at the name of a hurricane and its effect on death rates. So the researchers, and this was published in the Proceedings of the National Academy of Sciences. So this is a major scientific journal in which this was published. And what the researchers did was they said, let's take a look at a 60-year period of time. And we'll look at the 47 most damaging hurricanes. They excluded Katrina and Audrey just because they were so devastating, but they said, let's take a look at these other 47. So, and unfortunately, at least if you're on the East Coast, we've had our chance to become well acquainted with hurricanes this season. But most of you may know that hurricanes are named, they actually have a list that's predetermined, but every other one is male, every other one is female. They don't assign names to hurricanes based on any characteristics of the storm. It's every other one male, every other one female. So when these researchers looked at hurricanes and death rates, what they found was they found that there were about 23 average deaths if the hurricane were named after a male. But if it were named after a female, there were double the average death. So double the death rate if it were named after a female. So one of the postulations as to why this happened was the researchers said, well, is it possible that people simply didn't take didn't take the hurricane seriously if it were named after a female? This is Hurricane Susie. Well, how bad could this actually be? But if it's Hurricane Charlie, we better take this one seriously. So the gender, and you think about gender bias, could gender bias have played a role in the actions of people? And in this case, if that were to hold true, it was actually a life and death decision. All right, so I give you a couple of examples. They're built into us. It's who we are. They're built into us. It's not a matter of do we have our biases. We have biases because we are human beings. It's not a matter of if we have bias, but really it's a matter of what are our biases in all of these and many different areas. So we, again, just by virtue of us being human beings, we have biases in all of these areas. Again, often they're typically unconscious. So not what are it's really what are our biases, not if we have them. You know, the way this works, so we see something, we'll call it a catalyzing person or circumstance. We see something, and what we see goes through the lens through which we view the world. This lens, our background, the lens is formed by all of the stimuli that we have received in the course of our lifetimes, and it's an ongoing process. So our educational experiences, our life experiences shape this lens through which we view the world. So we see something, we see someone, goes through the lens through which we view the world, and this goes into our fast brain, the amygdala, the cingulate gyrus, the hippocampus. It's our fast brain. We see something, we react, often with emotion. We see the shadowy figure, we react, we move away. Often there's fear that's involved. That's how we spend about 80% of our waking lives, is in our fast brain, reacting. Again, many of our biases serve us well. We only spend about 20% of our time in the cerebrum, in the slow and thinking part of our brain. All right, so this is what we do. So the way we work, that when we see somebody, we see something, we make our associations quickly, and it's based on our past life experiences, our beliefs. We react very quickly. That's what allows us to get through our waking day. And then when we see something that's different, and again, only about 20% of the time do we actually think more slowly using our cerebrum. And we do so especially when we see something that goes against what our beliefs, what our lens tells us. All right, so when you see somebody, so what's actually there? What's in this picture? Well, what's in this picture are hair, eyes, glasses, a neutral expression, a mouth, a mustache. That's what's there. But what do we see? So through the lens through which we view our world, through all of our life experiences, what do we see? Well, perhaps we see this. Perhaps we see this. All right, perhaps we see it in one of, 100 or so different ways. Just by the number of people that are attending this conference, we could see that many different ways of viewing what's actually there. All right, and again, unconscious bias. These are some of the things that one might see, or a number of different ways. So when you take our unconscious biases, and we're going to get a little bit into this on Friday, but when we take our unconscious bias, microaggression. So now I know every single one of you have had the chance to experience microaggressions. We all experience them in some way, some more regularly than other. And I also know that each one of you have had the chance to do a microaggression onto somebody else. We don't do these intentionally. These happen, and these are based in good part on our unconscious biases. Microaggressions are brief and commonplace daily verbal, behavioral, or environmental indignities, whether intentional or unintentional, that communicate hostile, derogatory, or negative slights and insults towards marginalized groups. So this was a quote from Daryl Wing Sir. You're going to get to meet him just a little bit. I'm going to talk about some of his, but just a definition. And this is simply, you might think of it as an active form of some of our unconscious biases. So imagine how this affects our daily interactions. And then the people that you are caring for, right? All of you are caring for people in some way. Think of how this may affect the people that you care for, and then think of how that may affect ultimate outcomes from that. All right, and then these microaggressions, these biases. So this is a publication from what used to be called the Institute of Medicine. It's now called the National Academy of Science, Engineering, and Medicine. This is a publication a number of years ago called Unequal Treatment. And basically there is evidence that shows that bias, prejudice, and stereotyping, and these are all related to unconscious bias, they affect healthcare, and they typically affect healthcare in a negative way. I'm going to switch just a little bit, all right? I'm going to talk about race and racism. That's the second part of this of this, you might say, this bigger discussion, right? So race and racism, right? This is a very difficult topic to talk about, right? You know it. We certainly in the past several months there have been far more conversations that have happened. I don't know. Sometimes I think that in the last several months we've had more conversation than we've had maybe in the last 5 or 10 years. But with that being said, race is a very difficult topic to talk about. It's in the room. It's just something that is very difficult to talk about. It, people get defensive about it. People don't know much about it. Yet it's a topic that we really need to have conversation about if we're going to move forward. It's with us. You know it. You see it. You look at the news. You look at social media. Race is around us. It is part of our lives and affects the way we think and how we behave. What is race? All right, so having a little bit of an understanding, and again, on Friday, we'll get into this a little bit more, but just having a little bit of an understanding of what race actually is and a little bit of the history behind how race has developed is important when having these particular conversations. All right, so I'm going to go back. This is probably two-ish, maybe almost 300 years ago. Maybe the first set of descriptions of racial classification. So again, this is a really brief history lesson. So back in 1735, this was a Swedish botanist named Carolus Linnaeus. Described, if you look at the different descriptions, may have been one of the first people to actually describe race, meaning categorizing people based on physical appearance. Right, so you see some things here: Americanus, reddish, choleric, and erect; Africanus, black, phlegmatic, hair is black. So different classification based on physical appearance. You'll also note that in each one of these, there is some classification based on observed behavior. Now, I'm not sure who actually made these observations, but you can see Americanus, regulated by customs. So you can see all of these different descriptions, and this was perhaps one of the first times when we start to see classifications, categorizations of people. A few years later, all right, Johann Blumenbach was a student of Linnaeus. He actually described the different skulls. All right, so he did description of skulls, and it's thought that Blumenbach, did not really see any hierarchy. Yet, when he did the different descriptions of these groups of people, he put some hierarchy to it. He actually called the Caucasian skull the most beautiful form of the skull from which others diverge. So there's some hierarchy, superiority and perhaps inferiority. Thomas Jefferson wrote, so he writes in his book, "I advance it, therefore, as a suspicion only that blacks are inferior to whites in the endowments of body and mind." Again, it's descriptions, written descriptions that put some hierarchy, that put superiority and inferiority. So these are some of the things that have happened in history regarding race and classifications and hierarchy. Some definitions. Racism is a system of structuring opportunity and assigning value based on one's socially ascribed categories. So here we're talking about race. A characteristic of racism is that its effects can persist in governmental and institutional policies in the absence of individual actors who are explicitly racially prejudiced. So this we often think of racism as individual. one person doing something to another, or one person thinking something about another. In reality, this definition really alludes to structure. So you don't need the individuals, it's really the structures that are in place. So what is structural racism? So this is a definition by Dr. Kamara Phyllis-Jones, really an expert in this area. So structural racism is a system of structuring opportunity and assigning value based on race. So, and what does it do? It unfairly disadvantages some individuals and communities. It unfairly advantages other individuals and communities. So some get an advantage, some are disadvantaged. You put those two together, what that really does is it really undermines the realization of the full potential of the whole society. You just don't give people the fair chance to use their skills and talents. So that is, again, a definition of structural racism. This is not something that just happened in the last 10, 20, 30, 40 years. This has been with us for over 400 years. Perhaps it's gone on beyond that, but you think of race and racism and all of the things that happen in it. This is a 400-year long process. Sometimes we think of it in terms of Civil Rights Act. So that was maybe 45-ish years or so ago. We think about, post-racial society, things that come up like that. Well, that's actually only a small piece of the entire picture. So this is an ongoing, this is built within our structures over hundreds and hundreds of years. When I talk to healthcare providers about, what we do in medicine, so I'm going to use this as an example. Again, it's applicable to a lot of what we do, and it's not just in medicine. We tend to focus, at least in medicine, on physical factors, the individual factors, age, sex, race, ethnicity. Those are the things that we often focus on when we're trying to care for an individual patient. Well, when we do that, we actually don't look out at the bigger determinants of health, the social determinants of health. All right, so that age, sex, and hereditary factors, race and ethnicity, that represents only about 20% of an individual. In reality, there's an 80% that's out there. All of the things that really go into that individual, their place in society, their ability to work, their interactions, this is where racism has its greatest effect. It's on this 80%, not so much the 20% that we often tend to focus on. So again, this is, it's really hard. I have 30 minutes, I've got 15 minutes on the topic of unconscious bias, 15 minutes on race and racism. That's clearly not enough time. We could spend years talking about each one, but my intent was to get you thinking about this. The concept of unconscious bias, the fact that it's part of who we are as human beings. It's not bad to be biased. It's human to be biased. Well, we need to understand that because it affects our interpersonal interactions and our decision making. How about race and racism, right? Difficult topic to talk about. There's so much that's involved in it, but I wanted to just give you some food for thought in both of these areas. When we come back together again on Friday, we're going to go into more depth into each of these areas, and there's some thought-provoking exercises that I have that will work on each one and kind of tie them all together. So here's the call to action. This is the ask is that between now and Friday afternoon or morning, wherever you are, the call to action is that you think about this, that you reflect on this concept of unconscious bias. You reflect a little bit on microaggressions. You reflect on your observation about race, racism, and structural racism. Think about your experiences that you've had, and each of you have had some kind of experience in all of these areas. So when we come back on Friday, we'll have a chance to really bring those thoughts and experiences and hopefully bring it all together and have a discussion around some of these topics. So with that, thank you for your attention. It is an honor. It's a pleasure to be with you here today. I'm really looking forward to being with you on Friday when we can explore these in more detail. Thank you very much.
Thank you very much, Dr. Lopez, for that amazing presentation. Very informative and definitely understanding that we can't do it all in 30 minutes. But I think that you gave people some good nuggets to think about and chew on in preparation for Friday. So I want us to take a couple of minutes. We're going to go a little bit over to talk a little bit more about what you presented. So I want to encourage people to please go ahead and type in your questions or even comments. What came up for you while Dr. Lopez was presenting around on bias and racism? What came up for you? Any questions? No question is a stupid question. We want to hold space for everybody to engage in critical thinking and reflection. So there was a comment that came in, Dr. Lopez, while you were talking, and I want us to just go ahead and talk about that comment a little bit while people are typing in other questions. So the comment is, sadly, since COVID, I have faced more racism against Asians. And so I want to ask that you share your thoughts around that comment.
Well, my thoughts are yes. Yes. Yes, it shouldn't happen. It's happened. Again, without being too political, certainly certain leaders have promoted that idea, and it's really a big issue. So yes, you'll see the effects of racism in really all categories of people. But yeah, unfortunately, if you are Asian, you have become a target because of how this has been put out by certain leaders.
Yeah. And one of the things that, I often sort of think about as we talk about racism, especially in conversations that between people of color, is that, first we need to have these conversations, right? We need to have conversations around how racism is impacting us differently. It might take shape differently on a day-to-day basis. And so part of that conversation is, how do we support each other and find solidarity in our work? And so what does it mean for if we see racism occurring with impacting Black people, and then we see racism occurring impacting Asians? If you could give some thought around how do we support each other and how do we engage in the conversation, recognizing that racism impacts us differently. And so for some communities like Black and Indigenous people, there's a strong history, like you talked about, those 400 years. For other communities, their experience has been different.
Okay, so I'm going to not completely answer that, because then I want to entice everybody to come back on Friday, because I actually have some very specific suggestions around it. But here's what a couple general things that I'm going to say. One is, we need to look at each other as individual human beings, right? So not as a category, because you fit into general categories, but not everybody is that category. So I think it's important to recognize that we are individuals. We need to treat each other as individuals. Each one of us has an identity that's based upon our past life experiences. Each one of our identities and our experiences are important. they're valid, and they're important. And we need to view it that way, not as, well, mine's better than yours, or yours is worse than this. But if we start thinking that way, all right, so that's one, we have to recognize that this is work. This is work. You come to this session, the Friday session, you're not, no one's cured. You don't have the checklist that will get you through. This is lifelong learning. It's self-realization and reflection. It can be painful. We simply, though, need to be able to kind of give each other a little bit of a break. Let's have a real conversation. We're going to screw up when we have this conversation, but let's use that knowing that that's part of the process. And let's really try to understand each other as whole human beings.
Thank you. So we have another question. You mentioned bias by providers to patients. Any information regarding bias by patients to their providers?
Yeah, I have. I mean, it's in my own collection. There's a ton of literature that's out there. So yes, we know that happens. Again, sometimes it's unconscious. Sometimes it's overt. It's explicit. I don't want that person taking care of me. We see that happen all the time. In some ways, that's a little bit easier to deal with. So, for instance, we have a policy where I work, where we have almost a script. You are not allowed to do that. We will provide you with the best care, but you are not allowed to do that. In some ways, the explicit bias is easier to deal with coming from when it's coming from a patient. It's the unconscious biases that are very difficult to deal with. And I guess my easy answer is it's really trying to develop relationships so that people get to better understand and maybe let their guards down.
I think that those are great examples around how does bias show up in practice, right? And the way that we communicate and engage. Can you share with us your thoughts or some examples around how bias shows up in policies within healthcare institutions or other service providing institutions?
Yeah, that goes to the structural piece. So it's one thing to talk about individual bias and say racism. That's the structural piece. There's certain policies, there's certain practices in place. I'm just trying to think. So, for instance, a hiring practice. If a hiring practice is such that you need, for this job, you need a college degree, you need a master's degree, some higher education, is that a structural inequity? Because that will exclude a whole segment of the population. Now look, it's not as simple as that, because clearly there's expertise that's being looked for, but there are certain practices that we know exist that, well, maybe if you didn't have those practices, you could actually include more people for consideration. When you look at certain criteria that may be exclusive, you have put a structure in place that will not allow for, that diversity, does not allow for inclusion.
Thank you. And so we have another question. Asian Americans are often left out when people talk about health disparities or racial justice. How can we call people out and urge them to be more inclusive without alienating our allies or distracting people from the BLM movement? I think you talked a little bit about that in your first response, but I don't know if you want to expand more.
Yeah, the easy answer for me, because this happens at my institution, this happened in June. All right, so clearly back in June, the focus was on Black African American. That was the focus. By the way, June was Pride Month, so we essentially, and again, it's not that we wanted to. We were very aware of that. We essentially ignored groups of people because this was on the forefront. What I asked the people that I work with is I said, you've got to speak up and let me know, and we need to make sure we don't lose sight of everything. So the easy answer is find an ally. You find somebody who you know and trust, who is, well, again, an ally in what you do. An ally, I don't mean that just for LGBTQ. I mean ally in that somebody who's there standing for you. You find the allies and make sure that they are reminded that it's in the consciousness in some way. Yeah, that comment. If you're Asian, it's almost in some people would say, Asian's not really an underrepresented minority, so we don't really have to pay attention to that. That's not true, but that's often the sentiment. So for me, what I asked people to do at my institution was, you keep reminding me of this, because we certainly don't want to lose sight of it. We had conversations around that saying, listen, this is what's on the forefront, and this is what we're going to be dealing with, but in no way do we want to forget about you. So find an ally.
Mm-hmm. I think, in your response, a couple of things came up for me. One is that, the importance of us pushing race and ethnicity data, right? The need to disaggregate that data in a way that we can really see what's going on. And I agree, there are conversations around disparities. There are limited conversations around the disparities that Asian Americans and other people of color who are not Black and Latinx are facing. And so really thinking about what in our institution is allowing us to look at that in terms of data. And the other thing that came up for me as you were talking and these questions, I'm very grounded in what is solidarity work look like. And I think often solidarity work is not seen as, I will support your effort and then you will support my effort, right? That it's not always going to be, we're all at the table inclusive. That sometimes inclusivity means that I need to step back and see the work that needs to happen with you and your community, and make sure I am being honest and supporting that work in a way in which there isn't a need for me to sort of input what's going on in my community at this moment, right? And so when we think about solidarity work, it's not an either or, it's a both. And we navigate and negotiate how that both operates, so that we are looking at collective action and moving forward to address social justice issues.
I can see we need a little bit more time on our Friday session for discussion, which I mean, just look, everybody, you've zillions of questions. So there's your call to action. Bring those questions. I'm going to change my session a little bit. Actually, I think it would be good to have time for, this sort of discussion. I'll get my points in, but we're going to leave time for some discussion so we can get to what people really want to talk about.
Great. I'm excited for Friday, and I hope everybody else is excited. We have ran out of time for our session today. But again, come back Friday, 2 p.m. Eastern Standard Time. Dr. Lopez will be leading us, and it's not a didactic. It's really engaging activities, opportunities for you to reflect, opportunities for you to dialogue, and so that we can come out with something tangible that we collectively can think about and do, as we're all in this work addressing disparities and health inequities. Thank you, Dr. Lopez, and I look forward to Friday.
Great. I can't wait for Friday. It'll be good. All right. Take care.
Welcome to the session titled, What Happened to the Cure for Hepatitis B? We have two expert speakers today, Dr. Timothy Block and Dr. John Tavis, who will lead us in a discussion about progress and challenges towards finding a cure or functional cure for hepatitis B, and they will help us figure out what we can expect to see in the future. First, I would like to introduce Dr. Timothy Block. Timothy Block, PhD, is president and co-founder of the Hepatitis B Foundation, the Baruch S. Blumberg Institute, and the Pennsylvania Biotechnology Center of Bucks County. His work with Dr. Baruch S. Blumberg, Anand Mehta, and Raymond Dweck has pioneered the use of glycoproteins for detection of biomarkers of liver cancer, which led to the use of specific protein-based biomarkers to assess risk for both cirrhosis and liver cancer. His work with Dr. Su led to the use of microDNA detection in urine as a cancer marker. And most recently, he and his colleagues, including Jutao Guo, Dr. Haitao Guo, Andy Kukanati, identified small molecule inhibitors of hepatitis B virus, which was the initial technology in the creation of the company that was Encore and is now called Arbutus. Dr. Block has received numerous honors, including election into the U.S. National Academy of Inventors in 2017, appointment as a fellow for the American Association for the Advancement of Science, and a fellow of glycobiology in the University of Oxford. Just last month, along with his wife, Joan, Dr. Block was co-recipient of the inaugural AASLD Distinguished Public Service Advocacy Award. Dr. Block is adjunct professor at Geisinger Commonwealth School of Medicine and the University of Pennsylvania School of Medicine. With that, I introduce Dr. Block.
Hello, I'm Timothy Block, president of the Hepatitis B Foundation and its Baruch S. Blumberg Institute, which is dedicated to finding a cure for hepatitis B. I'm here today to think about the question and speak with you about the question as to what happened to the cure for hepatitis B. And I titled this talk, The Rise and Fall and Rise of Therapeutics for Chronic Hepatitis B. Again, I say, and rise again. Now, 10 years ago, we were on the verge of a cure for hepatitis C. There was great optimism, therefore, that there'd also be a cure for hepatitis B. You recall, by 2014, there was actually a definitive cure for hepatitis C. 10 years ago, again, China's emergence had increased interest from the Western world in hepatitis B because more than 90 million people, maybe 100 million people, are chronically infected with hepatitis B in China. In 2008, even, the Chinese government committed more than $1 billion RBM, hundreds of millions of dollars, to hepatitis B research. And investment and interest in hepatitis B increased in the Western world as well, commercially and federally. In the United States, for example, here's a cutaway of the amount of money being spent by the National Institutes of Health, National Institute of Allergy and Infectious Diseases, that's NIAID, on hepatitis B. A little chart I put together here that we got the information from the director's office. Now, there are many institutes at the NIH, and the NIAID is one of the main ones that looks at Hep B. And if you look at the numbers here, the amount of dollars spent on hepatitis B research in 2010 was $15 million. I know that's not a lot, but that's basic discovery research on hepatitis B. And that had been pretty flat for the 10 years preceding that. You can see it grows up to around 2019. The numbers we have are almost $30 million. That's a doubling. Still not a lot, but that reflects a degree of renewed investment or interest in hepatitis B. And overall, at the NIH, if you look at all the institutes, there's about $69 million spent on hepatitis B last year. Again, about a doubling from where we were 10 years ago. So there's considerable interest was growing in hepatitis B. 5-10 years ago, we saw a flood of interest at the Hepatitis B Foundation of the Blumberg Institute, from companies showing interest in this area. There was an exodus of hepatitis C scientists. So many of us were asking, what happened? 5-10 years ago, we thought the cure was going to be imminent. Well, why don't we take a look at first, what is the definition of a cure for hepatitis B? It's kind of blurry. It isn't for me. So let's try to define. For me, a cure is a real cure. It's a clinical cure. I define it clinically. That is, a cure for hepatitis B, in my mind, means someone with hepatitis B has the risk of getting sick from liver disease no more than that of anybody without hepatitis B. So just like the person next to you, if you have hepatitis B and they don't, A cure means you don't have any greater risk of sickness from liver disease than they do. And it also means, quite frankly to me, no more surveillance for liver cancer every year, no more drugs are needed, you're off drugs. That was considered to be actually kind of unrealistic, kind of too ambitious, and also impractical. It'd be impossible for drug companies to determine whether or not their drugs were working if we used my definition of a cure. So the community came up with a term they call functional cure, which is supposed to be a surrogate for the clinical cure. So the functional cure is something we can measure and show correlates, hopefully, with the clinical cure. A functional cure is defined as being off drugs, no more drugs needed, and a sustained virological and antigenic repression of the virus. That means that after a limited period of time of medication, there's no more detectable virus protein in your blood and no more detectable viral DNA in your blood. And ideally, and here's where some experts vary, ideally a functional cure also means there will be antibodies to hepatitis B in your blood, just as if you had been vaccinated or recovered from the infection. So where are we now then? That's the definition of a cure. What do we know now? Well, let's first look at the drugs that are available. In this chart, this is a timeline going back to the 1990s when there was no medicine for hepatitis B to the current time when there are 7 or 8 medicines for hepatitis B, depending on how they're defined. And what you can see for really 10 to 15, 20 years and more, we really had just about 6 or 7 drugs for hepatitis B. There were 2 categories: the interferons, interferon here, and then a smattering of nukes, nucleotide analogs. They are inhibitors of, and I'm showing here a picture of the virus polymerase. They all would whack down the virus DNA levels. And those were really the only oral class of medicines we had. A couple of years ago, there was a new medicine that came out, tenofovir alafenamide, which is a prodrug, an improvement on tenofovir, and it really is better, and it's much more potent. But it's a kind of a tenofovir knockoff. So how well do these drugs work? We've got them now. We've defined what a functional cure is. And if you take a look at these charts and tables that come from papers, scholarly papers dealing with the hepatitis B therapy, what you see here is if this is the percentage of people, we'll call it getting a functional cure, but it's actually either losing S antigen or sustained virological response. You can see over a period of time of up to 5 years, if you're on tenofovir alone, there's a small percentage chance that you'll be functionally cured. And if you're treated with tenofovir and interferon for just a year, but stay on tenofovir for more than 5 years, there's a 5 to 8% chance. And the likelihood of losing S antigen alone, this is actually somewhat less in the small percentages. Kind of confusing there, but what my point is the current drugs out there now can achieve a functional cure. Repression of viral DNA routinely occurs in most people who take it, but only between 2 to 7% of the people who stay on these drugs for 5 to 10 years will achieve the sustained virological response that we're calling a functional cure. And an even smaller number will lose the S antigen or the viral protein in the blood. So although the drugs out there now show us it is possible to medically achieve a functional cure, we need to do something to bring the other 93 to 98% of the people who don't achieve the functional cure on these drugs right there now. But at least we know the drugs out there now are good, safe, and do achieve functional cure for a small number of people. I also want to say that the drugs out there right now, it's now being shown if you're on them for a period of time to greater than 10 years and you have chronic hepatitis B, your risk of death due to liver cancer, and it's pretty scary, but risk of death due to liver cancer, which is a pretty definitive endpoint, goes down by 50 to 70%. That's showing that these drugs are working. But it still means that 30 to 40% of the people are still dying from liver cancer, even after an extended period of time on these drugs, and lifelong treatment is most likely needed. So we know that cures are possible medically. By medically, I mean by taking drugs, good drugs, but to really have a reliable, broadly active cure, one that we know is going to work, not just for 5 or 10% of the people. The field now knows what it's learned is we're going to need combinations of drugs that work against the virus. Here I'm showing the virus in this electron micrograph, and drugs that work on the immune system. So we're going to need a family of diverse acting, direct acting antiviral agents, DAAs they're called, direct acting antivirals. And we're going to need some drugs that probably stimulate the immune system to get us who have hepatitis B into making antibodies. And these, I'm showing a lymphocyte here, a T lymphocyte here. We've got to get drugs that stimulate the T lymphocytes and drugs that stimulate and drugs that target the virus directly. And we're going to hear more about this from Dr. John Tavis, who's going to speak right after me in this series. And what drugs did we have 10 years ago? This is a complicated table, but my point here is that 10 years ago, there were about 15 drugs in preclinical development and clinical development. That is in the investigational pipeline. 15 drugs. Sounds like a lot. It's actually not in this field. But as I'm going to explain in a moment, overwhelmingly, most drugs that enter the investigational phase fail. They don't make it. So you need many more than 1, 2, or 5 drugs. And so 10 years ago, there were 15 drugs for Hep B and really nothing for Hep D. And this is just showing the different kinds of categories. They weren't very diverse. We didn't have very many drugs other than the nukes. Not very diverse. And we know we're going to need to hit the virus at different steps. That's what I mean by diversity. And almost nothing against the immune system, or for the immune system, I should say. But by 2020, the situation is now quite different. Although we still only have 8 drugs approved, so that's only 1 more than we had 10 years ago by the U.S. Food and Drug Administration for treating hepatitis B. So 8, that doesn't seem like much progress. Look here, there are now 49 drugs in development, 11 to 14, depending on how you counted them 10 years ago, to now that's a 4-fold increase in the number of drugs. That is good news. Still not enough, I think. But if you look at the diversity population, the numbers in these different categories, that's also really nice to see. There's a great deal of diversity. If you look here, we now have drugs from all these different categories. These are the direct-acting antivirals. In use today, only the polymerase inhibitors. That's all we got approved. But now in development, RNase H inhibitors. By the way, and John Tavis, Dr. John Tavis is the inventor of this family of drugs. You'll be hearing from him. And but there are RNAi drugs, capsid inhibitors, cccDNA. If you're a student of hepatitis B, you know what each of these molecules and targets are. My point is 7, 8 different steps alone are now being targeted. That's great news for us. And there's also a diversity of drugs that are indirect acting drugs. Those are drugs that work on the immune system or on host functions that the virus needs to grow. We're going to hit the virus from many different angles. And that's the way it's worked for HIV. That's the way it's worked for HCV. There's not one drug, by the way, that's just used for HCV. There's still combinations. For HBV, hepatitis B virus, we still only have 1 target out there. So we're going to have to do better on that. If you look at where hepatitis C virus was in the beginning of hepatitis C virus therapeutic development, okay, now we have 15 drugs approved for Hep C, and they're curative. But before that, it took 700 investigational drugs to get these 15 approved. 700 entered the pipeline, probably more than that if you count the truly investigational drugs. And 15 entered. We have 49. So we have a fraction of that, and realistically, we're not going to approach the amount of investment that hepatitis C had, $25 billion. So, and they started here with only 6% of the people being treated. This is the percentage of people who got cured of hepatitis C or sustained virological response. In the 1990s, it was 6%. Then they added interferons, pegylated interferons, added a combination with ribavirin, then they're up to 30%. Then the big renaissance, the golden age of hepatitis C drugs. They then added direct-acting antivirals, the protease inhibitors, the helicase inhibitors, until finally the truly curative drugs like sofosbuvir, declatosphere, and the AbbVie drugs. And now people are cured all the time. Hepatitis B, we're here. We have to get to here. We don't have our 49 drugs being tested yet, being approved yet, but we have a number of drugs that are in the pipeline and now in the clinic, being tested in people. So my message to us all is a cure for hepatitis B. It's possible. It's possible. And it happens with the current medicines. And what that tells me is, one, the current medicines routinely control the virus. In almost everybody, the nukes will reduce viremia and improve outcome, much less likelihood of getting sick from liver cancer. They're not, but they're only really curative and reach the sustained virological response in a small fraction of individuals, 5 to 10%. But we know with hepatitis C, that was a stepwise process, and you need more drugs. We know that we have a number of drugs in development, and to routinely get to cures and sustained virological responses, we're going to need a diverse family of drugs, not just nukes, not just capsid inhibitors. We're going to need multiple drugs that are used in combination. And that's how we're going to get there. Now, there are going to be ups and downs in this development process. Already we know that several hepatitis B drugs that have entered the clinical phase, that is testing in people, have failed or disappointed. Springbank had a disappointment, terrible disappointment. Arbutus had a disappointment. These are, I'm just reprinting your headlines. They didn't come up as the graphic, but these are headlines taken from newspapers. Tyzica was discontinued. Novartis discontinued its entire antiviral program, all its hepatitis B program. And Assembly had a disappointing result just recently with its capsid inhibitor. Brace yourselves. Drug discovery is a roller coaster. And there are going to be ups and downs. What we have to do, and that's why your continued interest and support for the Hepatitis B Foundation is so important. Hepatitis B Foundation was there 30 years ago when there was no interest in hepatitis B. We were there keeping the pressure on the field. We need to continue with advocacy to make sure this support continues. We're going to need continued innovation. Drug companies, many of them, as I've shown you, they're going to lose their nerve. They've got to go to where the money is. That's the way they're structured. That's our system. We have to be there at the Blumberg Institute, at the federal level, across the world, to make sure that federal agencies continue interest, because there's still 250 to 300 million people chronically infected with hepatitis B. Keep the pressure on and continue to help the Hepatitis B Foundation. We were there in the beginning 30 years ago. We're still here today, the only organization in the world that continues to be focused on hepatitis B, patient advocacy, and drug discovery. So with that, I'll thank you, and we'll take questions a little bit later, I understand.
Thank you very much, Dr. Block. Next, it is my pleasure to introduce Dr. John Tavis. John Tavis, PhD, is a professor of molecular virology at St. Louis University and director of the St. Louis University Institute for Drug and Biotherapeutic Innovation. He received his doctorate in molecular virology from Penn State University and did his postdoctoral studies in molecular virology at the University of California, San Francisco. Dr. Tavis is chairman of the Scientific Advisory Council for the annual International Molecular Biology of the Hepatitis B Viruses meeting, that's a lot of words, incoming chair of the International Coalition to Eliminate Hepatitis B, or ICE-HBV, And he's a member of the Scientific and Medical Advisory Board for the Hep B Foundation and Baruch Blumberg Institute. His work on controlling cancer has led to him to receive the Mission Hero Award from the American Cancer Society in 2018. Dr. Tavis has studied hepatitis B replication mechanism and the biochemistry of viral reverse transcriptase since 1992. His current work focuses on the basic biochemistry of the hepatitis B virus ribonuclease H and developing drugs to suppress hepatitis B virus replication that target this essential enzyme. Dr. Tavis, over to you.
Hello. Today my topic is what happened to the cure for hepatitis B virus. I am John Tavis. I am a professor at St. Louis University School of Medicine in St. Louis, Missouri, and I'm also director of our university's Institute for Drug and Biotherapeutic Innovation. So the big question to start out with is HBV cure. Why do we need it? Well, most of you already know that, but basically it boils down to the fact that current drugs have big limitations. They rarely cure patients, less than 10%, probably closer to 5%, and they don't stop disease progression in everyone. Another problem is that the nucleoside or nucleotide analogs that dominate therapy need to be taken essentially for life, and they are not completely benign, although they are safe drugs. There are significant side effects, and so taking the drugs for life is not the best thing to do. Another big problem that we've got is that we really have only 2 flavors of drugs for hepatitis B virus infections. All of the nucleoside analogs work in the same way, and they all hit exactly the same spot on the viral polymerase protein. So they hit the same target. Then our other class of drugs is the interferon alpha derivatives, and they all stimulate exactly the same set of cellular immune responses. So we really have only 2 drugs, and neither one of them are capable of curing a large fraction of the patients. So there's been a lot of buzz about HBV cure going around in the community for a while now. And I can understand why patients and community activists want to ask the question, so what did happen to HBV cure? If they've been talking about it for so long, why don't we have it? Well, the short answer is that curing HBV is really hard. The longer answer is that drug discovery in general is very slow and expensive. It usually takes somewhere around 15 years to take an idea from the first time that somebody has the idea to generating first sale of a new drug to treat a patient. And making a new drug typically costs between $1 and $2 billion. This is extremely slow and extremely expensive process. But the good news is there's a full-scale effort going on in academia, the biotech industry, and the major pharmaceutical companies seeking a cure for chronic hepatitis B virus infections. So the biggest obstacle that we face, those of us who, like me, who work in the trenches trying to cure hepatitis B virus, is the viral cccDNA. That stands for the covalently closed circular DNA molecule. And that's really is shown in the blue circles in the middle with the big red arrow pointing towards it. And the cccDNA is the central molecule in HBV replication. It's the template for all of the viral RNAs, which are the form of the viral nucleic acid that carries information around the cell. And it's also the master copy of the virus that is found within the cells. So we've absolutely got to completely get rid of the cccDNA or shut it down permanently in order to cure HBV. And the biggest problem with that is that the cccDNA appears to have a very long life. In other words, it lasts for an extremely long period of time inside human liver cells. So how do we go about getting rid of the cccDNA? Short answer again, nobody knows. However, there's a few things that really guide our thinking about this. And the first and most important of them is that clearance of an acute HBV infection gets rid of the vast majority of the cccDNA perfectly safely. And the important part about that is your immune system, human immune system, knows how to do it. That's extremely important because when you set out to do a difficult task, it always helps to know that it's possible. And we know that it's possible to get rid of HBV out of a human body. Couple more thoughts to think about it is first, the cccDNA is not always completely eliminated, even during resolution of an acute infection. We know that because when some patients who have apparently completely cleared HBV and have been living perfectly healthy lives for many years, when they undergo B-cell immunosuppression or with a drug like rituximab that suppresses the production of antibodies in your body, the HBV can come roaring back. And so we know that in many patients who've even cured the HBV, apparently all by themselves, the virus is still lurking. However, the other thing we know is that the immune system can keep any residual cccDNA under control in almost all of the patients. So it's still there, but it's not a big deal because the immune system's doing its job. So these are really important things to know as you go about trying to design a cure. So let's define a cure. What is an HBV cure? Our goal is a functional cure. This contrasts to a complete cure, which eliminates all cccDNA and all other forms of the viral DNA. But although that sounds really good, that's likely to be impossible. A functional cure is defined as a functional cure, on the other hand, doesn't completely eliminate all of the cccDNA. So that kind of seems like we're settling for second best, but not really. A functional cure is no detectable cccDNA in HBV in cells or in the blood. So we can't pick it up at all, even with our ultra-sensitive assays. We can't find it. Importantly, from the patient's perspective, of course, is no disease progression. It doesn't get any worse, and we know that the liver can heal itself. And so, in fact, the liver will start slowly healing itself once we've got a functional cure. And then, just like the resolution of an acute infection, the immune system controls any residual cccDNA that's found in the body. So essentially, a functional cure is returning you to the state that you would find after a typical cure of an acute infection or clearance of an acute infection that never went chronic in the first place. Clinically, the functional cure is defined as undetectable HBV DNA and HBV surface antigen in serum 6 months post-treatment. This definition is subject to revision depending upon what types of things that physicians will be able to measure, but that is currently the definition of a functional cure. So what are cure therapies going to look like? Combination therapy is almost certainly going to be needed. And this is because HBV has many genotypes. Those are genetic variants of HBV floating around. And its disease progression amongst patients is highly variable. And so that means that no one drug will be suitable under all circumstances. So no one drug will be able to cure everyone. Another reason is that the cccDNA's durability means that we're going to have to hit it from many angles at a time. If it's something that's tough to hit, give it the old 1-2 punch rather than just trying to punch at it with one arm. And finally, cure therapy is likely to be long. My guess is around a year, but that's really just a guess, and need exceptionally safe drugs. Okay? So there's a high bar for us to meet as we develop drugs. So what types of drug discovery are going on for HBV right now? Well, cure therapy discovery research falls into 3 basic categories. The first is direct-acting drugs that target hepatitis B virus itself. For example, my lab is involved in that. We're targeting one of the viral enzymatic activities called the ribonuclease H. Another example of this is Viriad, which targets the viral DNA polymerization reaction. Then you've got host-targeting drugs that cause the cells, a patient's cells, to block HBV replication. An example of that is the approved interferon derivatives that cause the patient's natural defense mechanisms to kick in and suppress HBV. And then finally, we've got immune-stimulating drugs that train the patient's immune system to attack HBV. We really don't have many of those yet right now. There's a lot of research going on that right now. So I show this slide just to give you an overview of what's being attacked in trying to suppress HBV, leading into a cure with various combinations of these. I'm not going to go through this because even this very hideously complicated slide is not comprehensive. I show it just to say to emphasize how hard the scientific community, both in industry and in academia, are attacking this problem. Basically, if there's something that can be attacked, there's somebody out there attacking it. I also want to call your attention to the reference site that's listed down below. This is the Drug Watch site that is maintained by the Hepatitis B Foundation. It's very, very handy, and I even use it when I'm preparing for seminars. All right, so that's an overview of HPV current research, why we cure research, why we need it, what we're trying to get, and what we're trying to do. Over the last year or so, there's been some interesting advances that have been done that I want to kind of mention really quickly here. So the first one, and this is actually my favorite, because I'm a virology nerd and I really get into this type of stuff. This has to do with the half-life of the cccDNA. Half-life is a mathematical term that describes how fast a molecule breaks down, in this case, the cccDNA. Now, it has been assumed for a very long time that the cccDNA has an exceptionally long half-life, essentially approaching infinity. But those data that led to that assumption assume that therapy completely stops HPV replication. But in the last roughly 5 years, it's become really clear that that assumption is not right. Even during ongoing HPV replication or very effective HPV therapy, the virus continues to replicate. And so these people, Huang et al., took a completely different approach to this, looking at evolution and resolution of drug resistance in cccDNA, using it as a marker for which cccDNA molecules are present in the cells. And they found out that the half-life of the cccDNA among 10 patients varied from between 11 to 22 weeks, which is far, far shorter than the many years estimate that had previously existed. This is exceptionally important for the design of drugs against HPV, because a short half-life means shorter treatment durations may be possible, and it increases the number of different types of approaches that could eventually lead to a cure. Another thing that came out recently that's really interesting, and this it directly speaks to my statement earlier about how even during effective nucleoside analog treatment, there is still viral replication going on. These data explicitly demonstrate this. So the nucleoside analogs, such as tenofovir and entecavir and so on, can reduce HPV replication below the limit of detection or the limit of quantification. But even, it's important to notice that even the lower limit of detection, which means the very, very lowest amount that we could conceivably detect, that doesn't mean it's not there. It just means our assays can't pick it up. Maybe our assays aren't good enough. So what these authors did, Burdett et al., what they did is they took serums from patients with unquantifiable HPV DNA levels. So they knew they had a little teeny bit in there, but they couldn't measure how much. And they used that to infect chimeric mice that are highly sensitive to or permissive to HPV replication. And as you can see on the graph on the right-hand side, in all cases after a extended delay, which is very typical for an HPV infection, all of a sudden the virus starts replicating and coming up to very high levels in these mice. And so this proves beyond a shadow of a doubt that those trace levels of DNA that we can pick up with our ultrasensitive assays are actually functional. They are live HPV viruses. So this defines an awful lot about what we know is going on inside the cells. And so this is extremely useful information for those of us who are trying to design a cure for HPV infections. Another area where there's an awful lot of work, and this is a really important area, is the capsid assembly modifiers. And these interfere, as their name says, with formation of the viral capsid. The viral capsid is the protein shell that surrounds the viral DNA, and in HBV, the viral capsid is surrounded by a viral envelope or a lipid layer around it. So in any case, the hexagon shown in the little diagram there is the schematic representation of the capsid. In any case, capsid inhibitors disrupt formation of the capsid and cause the virus essentially to fall apart. These are going along very well in clinical development. There's 5 of them in phase 1 studies and 4 of them into phase 2 clinical trials. They have very promising antiviral efficacy. One example here is that 13 of 41 patients treated with a capsid assembly modifier from Johnson & Johnson had undetectable HBV DNA in their serum by day 29. So these are quite effective drugs. Now, some of these drugs have failed during early stage clinical studies due to toxicity, but that's why you do clinical studies, to find those things out and stop them. But the leading compounds are really quite well tolerated. One issue here is that HBV tends to develop resistance to some of them very easily, so these things should probably never be used as monotherapies or one drug at a time. But nobody's thinking about treating patients with one drug at a time in the future anyway, so that isn't going to be a big problem. I will be absolutely shocked if a number of these don't achieve licensure eventually. Another one that I really like is Merculodex B. That's its old name. It's also called Hepcludex or Bulevirtide. They just changed its name, so I've not gotten used to saying that name yet. In any case, this is an injectable drug that stops HBV from entering cells, so it's an entry inhibitor. It has already been conditionally approved in Europe versus hepatitis delta virus. That's important because hepatitis delta virus hepatitis delta virus steals the surface glycoproteins from hepatitis B virus and enters cells exactly the same way hepatitis B virus does. So if you can block hepatitis delta virus entry, you're going to block hepatitis B virus entry. And it is in phase 2 clinical studies versus HBV, and it's safe and effective so far. This is another drug that I'm quite excited about because of its novel mechanism of action. Here's something really interesting, is this is durability of HBV suppression by a drug class called small interfering RNAs, or siRNAs. These are RNAs that, the drugs are little RNA molecules, and they cause HBV messenger RNAs either to be turned off or shut down or destroyed, and this blocks production of the viral proteins. There's a number of them into clinical trials already. One of them has progressed to a full-scale phase 2 trial already. The interesting portion about this, because we all know this is going to work, those of us who are molecular biologists, this makes an awful lot of sense to try and do. The interesting part is that 15 of 38 patients who responded well to yet another Johnson & Johnson drug had durable post-treatment HBs suppression for up to a year. It was down 100-fold at 1 year. The reason that's so interesting is the drug's no longer there. These siRNAs don't last a year in a patient, yet the viral suppression occurred at 1 year afterwards. So this implies to me that the durability of this response could be due to partial reactivation of anti-HBV immune responses, which would be really nice to see during treatment of a patient. So finally, I want to talk about the last one, is the NAPs, the nucleic acid polymers. These come from Replicor, is the name of the company. These block secretion of the hepatitis B virus surface antigen from cells. They did a phase 2 study recently with 40 patients, and they treated them with the NAPs and then tenofovir, the particular form of it is Viriad, plus pegylated interferon alpha. So this is a triple therapy. And again, you can see how they're building these combination therapies that I've been talking about. Of these patients, 39% of them who managed to complete the 2-year trial achieved a functional cure. So there is a treatment out there right now that, at least in a very small clinical study, led to a 40% functional cure rate, which was much, much better than anything we've ever seen before. Some things to keep in mind about this is that flares occurred in all patients who had good responses, and it requires weekly injection of both the interferons and the nucleic acid polymers. So this is not going to be an easy therapy to take. It's going to require close monitoring by your gastroenterologists, but it does say that we're moving the bar and getting better at providing functional cures for our patients. So let's wrap up with some take-home messages. The goal of cure research is to achieve a functional cure for the patients. This is going to involve combinations of drugs that work in different ways. Over the last year or so, there's been some significant improvements in our understanding of how HBV persists, and that's extremely important for helping us design how to go about blocking viral replication and leading to a cure. There are many, many promising drug candidates that are being developed. The first wave of those is well into clinical trials right now, but those are by certainly will not be the only waves going into clinical trials. Functional cure rates up to 40% have been seen in a phase 2 study. So if you boil all this down, it comes to the fact that there is hope for chronically infected HBV patients. We're working at it. I really, truly think that a functional cure is coming. I can't project when it's going to occur. Science is not a crystal ball, but it is coming. I'm confident of it, and I'm very excited about it. So thank you very much.
Thank you so much, Dr. Tavis and Dr. Block, for those excellent presentations. This, when are we going to have a cure, and what might the cure look like? These are questions we get all the time from people who are living with hepatitis B around the world and from the people who work with them. So this is very, very informative for us. And myself, I know Dr. Block, you did a similar presentation last year, and just looking at the difference last year to this year, there's a lot more clinical trials happening now and happening very shortly. So it's exciting to see this progress. We do have some questions, and I'm going to read one at a time and we can go through them. The first question we have today is, and Dr. Tavis, we'll start with you and then see if Dr. Block has anything to add. The first question is, what are the prospects for a cure without any type of interferon? And this is from someone who was not able to tolerate interferon in the lonafarnib clinical trial through NIH.
My personal opinion is that the chances of an interferon-free cure are excellent. They may not be the first waves of functional cures that come out, just as they were that way with hepatitis C virus that Dr. Block discussed earlier. But I'm completely confident that we're going to be able to cure HBV infections without using interferon eventually.
That's great news. Dr. Block, did you have anything to add?
Well, just that I agree with that. There are already examples of individuals who can get functionally cured without interferon. It's a small number now. Those are the traditional treatments. It tells us it's possible. Dr. Tavis mentioned some of the examples. We're not seeing regular functional cures with the capsid inhibitors or even the siRNAs right now, although there are some studies out there with some immune enhancers. One example was some of the checkpoint inhibitors, which have been used. Those are the PD-L1 inhibitors. Maybe you've heard about them, Opdivo. They boost up the immune system. They take the brakes off. And there were some evidence that of course, that's of interferon-free cures. One other one at AASLD and at EASL, those are the liver disease meetings from the American Study for the Association of Liver Disease and European equivalent of that. There was a group that talked about using a nasal vaccine, which was very interesting to me, which in combination with tenofovir and some direct-acting antivirals also resulted in an unusual number of functionally cured people. So I'm also optimistic, but the question that you put forth to us was, what happened to the cure? There was all this excitement 10 years ago, 5 years ago. I think the answer is and you got to really from Dr. Tavis, it's taking more time than we thought. There has definitely been progress, but it's actually turned out to be more complicated, and we weren't all prepared for the ups and downs of the commercial drug development process.
Thank you. So I have a second related question, and I'm not sure if the data are out there, but do either of you know what percentage of people with chronic hepatitis B and/or D are unable to tolerate interferon-based regimens?
I think Dr. Block is probably a little bit more familiar on that. I do know that the interferons can be quite difficult to take for some patients, but I don't know the specific numbers. Perhaps Dr. Block is more familiar.
Thank you. So that's kind of a judgment of who can't tolerate interferon. Certainly no one with cirrhosis or advanced liver disease is qualified, should take interferon. So that represents a significant fraction, 10, 15% of people in the world with chronic hepatitis B, or maybe a little bit less than that. Then, of course, I don't think it's so clear. I don't think it's so clear. There's some genetic studies that suggest certain groups of people associated with certain genotypes of hepatitis B won't respond to interferon very effectively, and that represents the majority of people with hepatitis B. In other words, don't benefit very significantly from it. They're ruled out. Those who have significant adverse effects. I don't have that number in front of me, but I think that's a fairly small number of people, and it varies with your age. Children seem to tolerate interferon better than adults, and then of course we've mentioned, as you move along the hierarchy of liver diseases, severity of liver diseases, you shouldn't take it.
Thank you. Okay, the next question, has long-lived cccDNA been found in extrahepatic areas of the body?
John?
Well, that's actually quite a big topic. My postdoc in my lab right now would swear on a stack of Bibles that the answer is yes. Other people disagree with that. I mean, the way I come down on it is from looking at the assays, and obviously we're a close community. Dr. Block and I know each other well, and knowing the people and scientists who have done many of these studies, is that yes, it probably is. There is some evidence that is fairly decent, that it can be found in some unidentified fractions of lymphocytes. Those are white blood cells. What is lacking is any evidence as to whether or not that is functional, or it's just there and we can pick it up with super-duper sensitive assays. There is some evidence using an animal model called woodchuck hepatitis, and a virus called woodchuck hepatitis virus in woodchucks, that these trace levels can transmit between generations in a vertical manner. Again, they're right at the limit of detection, and so it's not completely accepted, but my guess is that it is present in extrahepatic sites at very low levels. But what is completely not clear to me is what is the biological or medical significance of that.
Nothing to add.
Tim, did you have anything to add?
No,
Okay.
no.
Great. I do have another question. Let me just pull it up. Okay, so the next question is, do you think that it will be a challenge to find treatment-naive patients who will meet clinical trial eligibility criteria?
Oh, I'd like to say something. That's a great question. It seems rather technical, but actually it's central to the topic, like what happened to the cure. Because I do think that with the quality of and efficacy of effectiveness of the current drugs, that did present a problem to find individuals. So all the drugs that are being developed now almost certainly have to be, it's a given that all the trials are done using what is called the standard of care, which already makes it a heavier lift to prove the efficacy of a new drug. I think that has been a problem, certainly in the United States, and that is a limitation. And of course, the development pharmaceutical firms have gone internationally. Of course, they've been in Europe, and development of programs in Asia, particularly in China, Korea, Taiwan, have been very, very helpful. But I do think that has been a problem. I don't know if that's your experience, John, but I think that's been our experience, the companies I've been involved with.
Yeah, no, I agree with that. It is a complication, but not a lethal one. As Dr. Block pointed out, these drugs are going to be used in treatment patients. We have to do our studies ethically, which means standard of care has to be your comparator arm. And the other thing about that is the vast majority of HBV infected people are not on therapy, even with the decent nucleoside analogs that we've got right now. So there's a huge pool out there of potential treatment naive patients. The issue there, of course, is finding them and recruiting them into the studies, which is
Right.
not a trivial issue.
Yeah, and getting them to
Yeah,
the
so
centers. But I want to make a call out to the ACTG, that's the AIDS Clinical Trials Network, because a few years ago there was a big leap there. That's the U.S. government-sponsored, NIH-sponsored program to test drugs for AIDS, and they opened up to testing first for co-infections for hepatitis B and of course hepatitis C, and that was a big boon. Because they have a very good network internationally, particularly in Africa, where we know there's a large population of people with hepatitis B, and now they can even take mono-infection trials. So you don't have to be co-infected. You don't have to justify the study necessarily in terms of its benefit in co-infection settings. By the way, an area we didn't talk about co-infections with HBV and HIV and co-infections with HCV. I want to just make a call out to that group, and because they've done a lot of good. They have several trials now finding patients all over the world.
Yes, so I mean, I think that's what a lot of us are finding when we work in the field. As you know, most of our Hep B United partners around the country, we are trying to find people with hepatitis B, right? So we do a lot of community-based testing in high-risk communities. The problem there is, as we know, most people aren't diagnosed, and then we struggle once people are diagnosed with hepatitis B and they know they have it. There are still so many challenges to getting them into sustainable care and treatment. So, I think that's one of the things that we're charged with is trying to figure out how to overcome some of them.
Didn't you set up a registration? Did you want to talk about that for a moment? That the Hepatitis B Foundation is implementing a clinical trials registration for individuals who might be interested.
So we have had we have different ways of doing it. We do now have a clinical trials finder on our website for both hepatitis B, hepatitis delta, and HCC for liver cancer as well, where you answer a couple of questions. It takes about 30 seconds, and then you are populated with any clinical trials that might be in your area. We also have been collecting for hepatitis delta patients around the world and providers. We've been collecting information, and then we blast out when new clinical trials are available. But of course, people have to find us in order to get that information. It's harder to find the people who don't know where to go to find the information. So it's difficult. It's definitely a challenge. Let me just check and make sure. I don't see any other questions here. So I think we can, and we're just about back on time now, which is exciting. I just wanted to wrap up and thank you both very much for these updates. And if any questions come in after the fact, I will make sure to send them to you so that we can get responses back to our participants. But thank you again on behalf of Hep B Foundation and APCHO and Hep B United.
Thank you.
Excellent. All right. Thanks for having me.
Good.
Thanks. Take care.
Thanks, John. Thanks, Sherry.
Thank you so much to our wonderful panelists from the first part of our day. I don't know about you, but that was quite exhilarating and such powerful presentations from Dr. Lopez and Chioma, as well as from Tim and John, and the conversation about the cure, all really powerful in so many different ways. So we are now at break time. We're going to take a 15-minute break. But before that, I just wanted to remind everyone, you can provide feedback on each individual sessions in the polls tab right next to the live stream window. So those are for individual sessions. But overall for the event, you can also access the event survey in the left navigation menu. So be sure to do that before you head out for the day or head out in the summit in general. And I don't know about you, but I've been enjoying the views outside everyone's windows. So Paula Wong, the deer family outside your window is amazing. So that is all, closes out the first part of our time together, and then we'll see you back in about 15 minutes. So that would be about 3:20 p.m. Eastern time for me. We'll see you back then for our next panel on elevating the patient voice. Thanks, everyone.
In 1989, I came to the US from Taiwan for my PhD studies. After I finished my degree in 1992, I got a call from my sister. She said, "Our brother is in the hospital, you need to come back." So I went home to see him and our family. That's when I found out he had liver cancer caused by hepatitis B. He was infected when he was born. I worried about my sibling, my aunties and uncles, and I worried about myself. I wonder, am I also hepatitis B positive? I got tested and learned I do have the virus. My brother started treatment for liver cancer and hepatitis B. Later, I got treatment for hepatitis B too to prevent liver cancer because I also had liver inflammation and severe fibrosis. Later, we found out my wife also has hepatitis B. When she got pregnant, I thought, how can we protect our next generation? We researched and got her treatment with antiviral during her last trimester. This, together with the hepatitis B vaccine and immunoglobulin, successfully protected our son. As years passed, we wanted to help other families as well. So we set up a Taiwanese hepatitis patient group. We help answer patients' questions and make sure people get the treatment and support they need. We gather regularly to talk about living with hepatitis and about prevention and treatment. Today, my brother has been cured for 10 years. This is rare for liver cancer. I feel so grateful to him because if he hadn't got through what he did, I would never have known I have the virus. My wife and I are living healthy and continue taking the Hep B drug. And all of our kids are free from hepatitis B. Just be treated.
Hi, everyone. My name is Rhea Racho. I'm the Public Policy and Program Manager for the Hepatitis B Foundation. I work out of our DC office, helping to manage our policy and advocacy initiatives, and I also have the privilege of managing our patient storytelling programs, including the Just B campaign, which the video that just played, Jackie's story, is a part of. And I'll be talking more about the Just B campaign shortly. But I just want to welcome everyone and thank you for joining this session, Elevating the Patient Voice. During the first part, we'll be providing an overview of the Hepatitis B Foundation's storytelling and patient engagement programs, followed by a Q&A with the presenters. And then we'll be joined by a live panel of patient advocates from our Just B campaign, who will share their stories and discuss ways of increasing and improving patient engagement in hepatitis B research, outreach, education, and advocacy. So starting with a quick overview of the Just B campaign, which officially launched in 2017 with our first round of videos that we created in partnership with Story Center and APCHO. Just B was the first national and multilingual storytelling campaign to focus on hepatitis B. The campaign primarily utilizes digital stories or videos, but we also develop and disseminate printed materials and online content, while also conducting both in-person and now a lot of virtual storytelling events as well. This program has been supported by individual donors as well as grants from Gilead, Arbutus, Dynavax, and Janssen. The goals of the Just B campaign are to increase awareness and strengthen advocacy around hepatitis B, to help decrease Hep B-related stigma and discrimination, to educate communities about the importance of Hep B testing, vaccination, linkage to care and treatment, and above all, to really empower people living with Hep B to be able to share their stories effectively and widely in order to raise awareness and understanding around the disease, as well as to ultimately inspire people to take action and to drive policy change as well. So again, the video that played at the start of this session, Jackie's story, is one of 40 videos like that we've created within a 3-day workshop facilitated by our partner, Story Center. Following their digital storytelling methodology, these are hands-on workshops that guide participants first through an activity called a story circle, and then over the next couple of days, guiding participants through script writing, audio and voiceover recording, image gathering, storyboarding, and video editing. And with each of these workshops, we've found that the process itself of bringing people together with similar experiences to create their videos is as important or more important than the final product of the video itself, because we've really seen that the workshop experience provides connection that some people living with hepatitis B have never had before, provides some healing, some more education around hepatitis B, builds community, and really is a kind of a jumping off point to help develop more interest and engagement in public speaking and leadership among the participants. This slide, here's a quick overview of the major milestones of the Just Be campaign. So we've hosted 5 workshops with Story Center for a total of 40 participants from 20 states and Canada. Of the videos we've produced, almost half of them have translated versions available. So we currently have videos in 12 languages, including English, across all of our Just Be Story Bank. After the workshops, our main focus is to keep promoting and maintaining engagement with our storytellers. So this can be through inviting, hosting national or local storytelling and speaking opportunities, providing ongoing training and support, as well as organizing networking or other types of events and activities. We also conduct periodic evaluations of the program, looking at both the impact on storytellers who participate in the workshop and the campaign, as well as the impact on different audiences or the viewers of the videos. We use a lot of different strategies and different channels to share the Just Be stories in the US and also internationally, including what you see here. On this slide, we have a story that we feature every month in our newsletters, on our website and social media. We look for media spotlight opportunities, do press releases and blogs, connect storytellers to requests for interviews or quotes. We host or we invite storytellers to advocacy events when we were doing those in person or when we're doing virtual meetings with members of Congress and things like that. Doing virtual briefings or other in-person events where we're engaging congressional staff. And then locally, which I'll talk a little bit more about too, with Hep B United testing or awareness events, and also different public health conferences. We've submitted to film festivals. And then of course, we also have printed materials and things that go along with the videos. And next, here's a closer look just at some of the different components of our program evaluation, which includes tracking, collecting, and analyzing data around the actual campaign reach and number of video views that we get through our own channels and also through partner social media or newsletters that help us disseminate the stories. We look at the impact on storytellers themselves. So we do this through a post-workshop survey and through follow-up interviews. We look at the impact on viewers and how useful, and also how useful the videos are for our partners. So I just pulled up a couple of quotes that I thought were pretty that stood out from some of the from the one-on-one interviews that we've done with patients after they participate in a storytelling workshop. So going back to the idea that that process of creating the video is really impactful. One person said that the workshop was a true blessing. Before, I felt isolated and disconnected, but after the workshop, I felt a great sense of family and inclusion. I hope that our stories can change not just how others view those who are affected, but also that more emphasis would be placed on treatment and cure for this condition. Another person said that they were feeling lonely when they first got diagnosed, but when you hear other people explain that they've gone through that same fear and have that same sort of feeling of isolation, it was really impactful. It made them recognize that this doesn't have to be a lonely or solitary thing, and that there are other people who have the same struggles and experience the same fear. That was incredibly powerful and something that I didn't know I was missing. And then a quick look at one of the ways that we have attempted to evaluate impact on the viewers of the stories was actually by teaming up with Hep B United partners to conduct local story screening events. The ones that are noted here on this slide, I think were all done in 2018, but we connected storytellers in areas where we had Hep B United partners and had provided some surveys and other materials and things to ask participants after they watched the video. Usually these were some sort of Hep B education event, and that incorporated a video as well as a storyteller in person to share their story. So through those, we collected surveys from 8 screening events for a total of 188 attendees, and the majority of the respondents reported an increase in their HBV knowledge or their understanding of Hep B transmission, risk factors, prevention, and treatment, or impacted populations. But I think the more interesting thing are some of the quotes that people put down. Again, this is from the surveys, so I really enjoyed the personal stories. HBV has such a significant impact and realism that is not accessible when approaching the topic from a clinical or third-person perspective. So having a personal perspective was really more engaging for that person. Another person said that the stories were extremely powerful, paired with data and key messages. This was a very effective presentation. And just to, let me advance one more slide. So just to kind of wrap up with a few reflections or thoughts on the last few years of the storytelling program, we've really seen through our experiences working with storytellers and patient consults that there still is a great need for more personal stories about hepatitis B, but storytelling has proven to be an effective and compelling platform for raising awareness and amplifying really important health education and prevention messages, encouraging dialogue and action, and advocating for policies and programs and services that support people living with Hep B. We know that amidst the general lack of awareness there is around Hep B, it's so important to engage people with lived experience to speak out about the challenges and obstacles to Hep B screening and prevention and access to care. So as we begin to see more momentum building towards Hep B elimination and towards finding a cure, or at least new potential treatments that are in development and moving through the pipeline, we're really seeing increased opportunities as well to elevate the patient voice and have patients directly inform drug development and clinical trials and Hep B research in general. And so on that note, I'm actually going to pass it over to Sherry and Yasmin, who will talk more in their presentations about the Hepatitis B Foundation's efforts to document the patient experiences, wants, needs, and challenges. So first up, I will pass it over to Dr. Sherry Cohen. Sherry is Senior Vice President of the Hepatitis B Foundation and Associate Professor at the Baruch S. Blumberg Institute. Her work focuses on reducing health disparities related to hepatitis B infection and liver cancer. Sherry is co-chair of Hep B United, as you met her earlier, co-founder of Hep B United Philadelphia, and chair of the Coalition Against Hepatitis for People of African Origin. She received her MPH from Temple University and her DRPH from Drexel University.
Hello, I'm going to be talking a little bit about our hepatitis B patient engagement program from 2020 and discussing some of the findings from our June 2020 externally led patient-focused drug development meeting, or PFDD. One of the things that we know has been missing from the discussion around eliminating hepatitis B has been the lived experience. We decided that we wanted to play a role in documenting the lived experience of people with hepatitis B and asking some of the very important questions. So first, what is the impact of people living with Hep B? How does it impact their lives? And so we wanted to look at both physical, emotional, professional, and the social impact of people of having hepatitis B. And we also wanted to focus a little bit on stigma and discrimination because we know that that is a very important component of having chronic hepatitis B infection. We also wanted to learn from people living with Hep B what they prioritize in terms of treatment. So we wanted to document current treatment experiences and the challenges that people face currently, and then get their thoughts and perceptions on the future. What kind of ideal treatment are people looking for, and what do they want in terms of clinical trials? And this is really important because now, as we have heard from the Cure update, we know that there will be some new clinical trials for hepatitis B and Delta coming through the pipeline in the next couple of years. So how do we ensure that we have diversity and inclusion in those clinical trials and make sure that the entire world of hepatitis B is included in those clinical trials? And then finally, we wanted to start asking questions about patient-reported outcomes. We know that obviously clinical outcomes are really important and will be important with future clinical trials and future treatments and hopefully a functional cure. But we want to make sure that as we're moving towards functional cure, that we are asking patients what else they want. What other kind of outcomes do they want that are maybe physical or emotional or stigma related, so that we can start including those in some treatment regimens and as well as guidelines and algorithms. So here's what we've been doing. We hosted our externally led PFDD in June of 2020. We wound up with because it was virtual, obviously because of COVID, we wound up with a lot more participants than we would have had. So we opened it up worldwide and had 650 participants. We had 12 expert panelists sharing their experiences and answering focused questions. And we had about 300 email comments from people around the world that were sent to us. We also, in 2019 and early 2020, conducted 24 in-depth interviews with people who have chronic hepatitis B infection in the US. We completed data mining and a qualitative data analysis of a sample of 10,000 email consults that we received in 2019. We conducted an online survey in late 2019, early 2020. We had about 1,700 respondents around the world on that. And we are in the process of putting together very targeted focus groups in the US and outside the US for 2021, looking more at what people want in clinical trials. So taking what we learned this year and using it as a launching point for more focused discussion. Here's what we found from the PFDD, and we're seeing that as we analyze the other data, it's starting to look the same and confirm what we're seeing. So we saw there's quite a bit of significant and emotional impact for people who are living with hepatitis B, and it does appear to reduce quality of life and impact enjoyment of daily life. And this is among people who often don't have physical symptoms, yet they still feel a daily impact. And a lot of times it focused on fear of liver cancer, fear of progression to liver disease, fear of transmitting the virus to others, and also a lot of themes around feeling shame and stigma and isolation. In terms of physical impact, fatigue was the #1 discussion that day. It was the theme that we kept seeing over and over again. We also heard from patients that chronic hepatitis B impacts their family and social relationships, as well as their education and career. So we were seeing people who who talked about maybe not wanting to date or scared about transmitting to others, or maybe even scared of having children and the impact that it would have on them. And then, of course, both in the US and internationally, we heard from people who were discriminated against, and it was affecting their ability to find a career and get a job. We also saw people talk about their treatment challenges right now, both inside the US and outside, where cost and access to treatment was a big issue. Of course, outside the US, we did see a lot of comments come in from people who were just not able to access hepatitis B treatment right now at all. But we also had a lot of people talking about the emotional and fear-related burden of taking a pill every day for many years, and how it's a constant reminder of what they're living with. Of course, across the board, we saw a strong desire for losing surface antigen and for reducing their risk of liver cancer with a future treatment and hopefully a finite treatment. So people don't want to take drugs forever, right? And I think we all knew that, but it's really nice to have it documented. And finally, we did see quite a few people who were not currently taking treatment because they didn't fit the guidelines for treatment. And those folks do feel nervous and uncertain about the future. They feel as though they're not really able to make a difference. They're not able to do anything about their hepatitis B right now, as opposed to people who are on treatment who felt like they were more empowered and that they were doing something positive about their future. In terms of future treatment and clinical trial preferences, we did see a preference for oral treatment, but injectables and IV infusions did seem to be acceptable by many, as long as the symptoms were considered to be mild and limited. We saw some willingness to participate in clinical trials for a possible functional cure. We did see more people outside the US, and I think when Yasmin talks about the survey, she'll be able to confirm that. Though comments coming in outside the US, people seem to be more willing to participate in a clinical trial. Those in the US seem to have more questions. So number one, what would the side effects be? Number two, making sure that any clinical trial didn't interrupt their daily life too much. So having to travel for many hours to and from, or having to go for checkups every week, every other week. Of course, people were concerned about safety and about flares of their hepatitis B and damage to their liver and other organs. And really, people were more likely to participate in a clinical trial or to think that they would participate if there was a higher chance of functional cure, so 50% or higher. We did see questions mostly from people who had young children, and then people who were older. More questions about, do I rock the boat at this point in my life? Would I want to start a clinical trial now, knowing that maybe I'm older, maybe I have more comorbidities, maybe it's not something I want to rock the boat with and take an experimental treatment. So I do think, we're starting to see potential differences in whether people will participate in clinical trials based on where they are in life. So finally, for next steps, this was just a quick overview of what we found. Everything is documented. We have the report, the PFDD report is now online, so I encourage you to go and take a look at it. We will be disseminating it widely. We are going to be triangulating the data from all of the data components and hopefully publishing in a number of peer-reviewed journals to get this information documented and out there and sort of get the patient voice out there. But we're also going to be creating some patient-focused and community-focused materials to take what we're finding and break it down and get it out into the community. And of course, the people who participated in the PFDD, we want them to be able to see how it went and to see what we learned from it. Hopefully, what we learned here will help clinical trial developers and drug developers. So we'll be working with researchers over the next couple of years, linking together the community patient group and the research group. And hopefully we'll make a difference and improve clinical trials and also improve participation in clinical trials for the future, because without clinical trials and participation, we won't get to functional cure. So hoping that, that these programs really make a difference. And that is all I have for today. Thank you.
Thanks so much, Sherry. Next, I'd like to introduce Yasmin Abraham, who works as a public health manager at the Hepatitis B Foundation. She has 20 years of experience in healthcare management, health systems strengthening, and health policy in low-resource communities. In the past year, Yasmin led the patient engagement program, hearing from patients living with chronic Hep B through an online survey and one-on-one phone interviews. The insights obtained helped guide the agenda for the first ever Hep B patient-focused drug development meeting, or PFDD, that Sherry just spoke about. And the report from that will inform the Hep B community partners, regulators, and industry about patients' challenges living with chronic Hep B and their hopes for and perspectives on new Hep B treatments. Yasmin is a medical doctor, holds an MBA in healthcare and a PhD in health policy. So I'll turn it over to Yasmin now to share more about the survey and interviews.
Hello, everyone. We believe in the power of the patient voice, and this is why through all the several platforms that Sherry has just shared, we try to listen and we try to understand what patients need and really want. Today, I will be sharing with you some of the preliminary results of the online survey and the in-depth telephone interviews with people living with chronic hepatitis B. So we tried through the survey and the interviews to document the physical, emotional, professional, and social impact of chronic hepatitis B, the challenges of living with CHP. We tried to understand the experiences during the treatment journey, challenges, and the perceived value of current treatments, and what patients think of about future treatments and clinical trials. What are their perceptions about clinical trials as well? For the survey, we had about 1,700 survey participants, and 81% were less than 45 years old, so they really have a full life ahead of them. 67% of participants were male, 83% were living outside of the United States, and really the majority of participants were from Western Sub-Saharan Africa, Southeast Asia, and the Pacific regions. And for those from the United States, they were fairly distributed across the country. 50%, when it comes to ethnicity, 50% were Black, either African or African American, 29% were Asians, Asian American, Native Hawaiians, and Pacific Islanders, and 13% were white. 53% were of participants were diagnosed in the past 5 years, and 56% had an experience with CHP medication, either in the past or currently taking medication. And 79% of those taking medication have been taking medication for the past 5 years. The emotional burden of living with chronic hepatitis B is significant, and not dismissing the physical burden, but the emotional burden was really reported as a significant burden. 55% of participants said that they fear developing liver cancer, and 48% feared living a shorter life, while 40% were constantly worrying of transmitting the virus to others around them. The social aspect of living with the disease was also significant, as 62% reported feeling life is less enjoyable, and 58% fear facing discrimination. 48% worried that their relationship with their family and friends would be negatively impacted. 47% felt shame, and 43% were feeling like avoiding others. There was a lot of reporting about feeling isolated and not really able to enjoy life. And many were unable really to share their status with close friends, family, and their close network. So 44% did not share with close friends, 26% were not able to share their status with a spouse or a partner, and 21% were not able to share and did not share their status with their family members. And when asked about the reason for not sharing, 37% said that they feared of being treated differently, 33% feared discrimination, and 24% feared of worrying their loved ones. Not surprisingly, with all the responses that we've been getting through all the platforms, 25% of respondents have cited more than one reason. So not only one reason, many of them were having a lot of worries and fears if they shared or disclosed their status. We looked at so many of the challenges living with chronic hepatitis B, and we wanted to understand more about this. And as you can see, the regular daily life struggles due to hepatitis B do not really differ based on where you live. They are very much similar between those who live in the United States or live elsewhere. And one of the participants really were having a hard time managing fatigue. It's been always reported constantly, or maintaining a healthy diet, and 41% said that staying current on the latest hepatitis B research and being gaining knowledge about what's the updates in this field was also a struggle and a challenge that they faced. When it comes to managing hepatitis B and managing their disease, there were many struggles and many challenges, but mostly they were related to cost, as you can see. Cost of testing and ultrasound, cost of visiting the doctor every 6 months, and going to medical checks every 6 months was also a challenge. Finding a doctor who's knowledgeable about chronic hepatitis B was also a challenge. And as you can see, these are also shared challenges and struggles. However, more so for those who live outside the United States than those who live in the United States. For example, 57% of those who live outside the United States was finding difficulty finding a doctor who's knowledgeable about hepatitis B. 64% of those who live outside the United States said that the cost of the doctor's visit every 6 months was a challenge, and similar for the blood test and ultrasound. Definitely, that's when cost becomes a challenge, then we know that this is a barrier to access to care. We also asked participants about other barriers to access chronic hepatitis B medication, and we had several responses, and they were a little bit different between those who live in the United States and those who live outside the United States. For example, for those who live outside the United States, of course, as the previous slide showed us, the cost of medication was a challenge. The out of stock, we know that in many low and middle income countries, there are a lot of challenges with medication supply chain. And of course, the constant reminder of their disease, taking a daily pill was a challenge. For those who live in the United States, physical side effects was more notable. Also, the cost of medication, even so with those who have health insurance, was a challenge. Some of the process for the pharmacy, specialty pharmacy, was also a challenge. And again, since the health insurance or finding a prescription plan that covers the medication for chronic hepatitis B was also a challenge cited by those who live in the United States. For telephone interviews, we conducted 24 telephone interviews in depth with people living with chronic hepatitis B living in the United States. 50% of participants were female, and about 15 of the participants were currently taking medication for hepatitis B. The physical and emotional impact of living with hepatitis B was significant, constantly reporting experiencing stigma and isolation, anger, and fear of developing liver cancer. The physical also pain and fatigue were particularly among the most frequently cited physical impact, and that affected the daily activity and daily routine of those patients. The impact of hepatitis B on career choices was also significant. Many have mentioned that they avoided jobs that required them to disclose their status, or avoiding jobs that were physically taxing, or even just the idea of changing jobs or finding a different job for fear of losing their coverage that they enjoyed with the current job that they have. So they didn't even have the option of job mobility. That was affected as well. They also mentioned that finding the right doctor who knows about hepatitis B was a challenge, and they cited so many times concerns over treatment costs, even among those who had health insurance. And again, taking the daily pill was a challenge that was constantly coming during these interviews. So preliminary considerations and thoughts on the responses that we have received from the survey and the interviews and all the platforms. The good thing or the strong thing is that we really had consistent messages coming from or coming through the different channels and platforms that we used. The challenges and struggles of people living with chronic hepatitis B are global and shared regardless of where you live or how old you are. And these challenges and all these concerns and burdens, they really highlighted the need to communicate these emotional and physical burdens of living with chronic hepatitis B with healthcare providers, the industry, and policymakers. We really need to reach the point or achieve a comprehensive approach to managing hepatitis B, where not only the liver function tests and the viral load and the ultrasound results are the only thing that matters, but also we need to incorporate the help of social workers, psychological assessment, every aspect, so that patients can really feel that all aspects of their life is being managed, and they can move on and proceed and achieve their goals and dreams in life. There is definitely a need to increase knowledge and awareness about hepatitis B among the public, and the modes of transmission, and reduce the stigma about the disease. We need to enhance efforts to address discrimination against people living with hepatitis B. And of course, there's a lot to be done to fill the gaps in the continuum of care. And we need to increase affordability and accessibility to care and medications. Thank you.
Great, thank you, Yasmin, and thank you again, Sherry, for both of your presentations. We are going to spend a couple minutes now going through some of the audience questions. So you can continue to ask them, put them in the chat box if you have them. But the first question that I have for either of you is, do we have data on how people learned about their Hep B status or how they were diagnosed?
Yeah. Yasmin, do you want to start us?
Yeah, so with the survey, there were so many different reasons that participants have provided, both in the survey and in the interviews. What was really striking is that only even less than 20% of participants had symptoms. So the reasons were varying between either testing during regular checkup, during pregnancy, for marriage, for immigration, work, school, blood donation. So these are all where the majority of the reasons, and only less than 1/5 that were actually having symptoms. That's what I like what we learn.
Great. And so there was also a question about what is the next step in all of this work? What would come after the PFDD meeting?
That's a great question. We have so many plans. So the PFDD meeting resulted in a report, which we're hoping that the FDA and the drug development companies and nonprofit NIH, and Bloomberg researchers will all be using the FDA as a way to help move drug development forward and think about improving clinical trial diversity, improving clinical trial participation, and including patient-reported outcomes in management and in clinical trials. We are actually finding multiple ways now of getting the information out. So we're going to be publishing all of these results in peer-reviewed journals, but also trying to present as much as we can to community-based organizations, to patients, patient groups. So of course, we can't do anything in person just yet, but we're going to be trying to do some webinars and virtual town halls and create sort of simple fact sheets and one-pagers for people around the world to be able to use the information. And hopefully, maybe by the end of 2021, we'll be in person and we'll be able to host some patient-focused conferences and present in front of providers and others to help incorporate what we're learning. But we're still collecting data. So we're going to be doing a bunch of focus groups as well in 2021, focused mostly on diving deeper into what we've started to learn and figuring out how we can improve clinical trial participation and diversity for Hep B.
That's really exciting. Yeah, I think we'll put out information, press releases, and posts on our social media whenever new, publications or parts of the patient engagement research is completed. So definitely stay tuned and look out for more from the focus groups next year. Another question, so this one I can answer. This one, it's around the storytelling workshops. How could somebody sign up for a storytelling workshop? That's a great question. Unfortunately, we didn't do a lot of promotion around the Just B participation this year because we couldn't do in-person workshops. But basically, there's an online application. If you go to hepb.org//justb on that main page, there's a link to an application that patients can fill out at any time on a rolling basis, and we collect information there, or people can email me if they have questions, and we just review. It asks a few things about just kind of their basic experience or what their Hep B story is, and if they're comfortable with technology or video editing. They don't have to have that, but it's just something that's useful to know since that's part of the workshops. And then usually what we do is we look through the applicants and try to prioritize geographic areas or communities or languages that or types of stories and experiences that we don't have yet in our story bank, and we invite those people to join us for a workshop. And then we hold on to names of others who, if we don't have the capacity for the next workshop. And then just to give a preview for 2021, we're hoping to do an all virtual workshop with the same partner, Story Center. So it should still have very similar, or actually the same product, but also the process of gathering people together will be a little different. It'll be remote, but we hope that it still has that the aspect of bringing people together to share their stories and build community with other patients. So we'll share more information about that, hopefully in the spring of next year. So back to the patient engagement questions. Sherry and Yasmin, what is the best way for providers and community organizations to promote clinical trials?
That's a great question.
That's a good question. Yasmin, do you want to start?
Well, that's actually a great question, because it taps right into the concept of diversity of participation in clinical trials. This is really important. I know that our Drug Watch is a great tool to learn about clinical trials and whether it's possible to participate or not. But educating patients about clinical trials as well, about what it entails to participate in a clinical trial, and what comes with that is really also an important thing, because through the email consults, the survey, the interviews, there has always been a lot of thoughts and conceptions about clinical trials that need to be clarified on the patient side, but also there is a lot of communication between the industry and the patient that needs to be done. I don't know, Sherry, if you have also other.
Yeah. No, those are great thoughts. I think however you engage with your patients in the community, making clinical trials part of the discussion is a really good step. So we've done this in the past, where you can host small patient workshops where people can come talk about clinical trials in general. We've actually, there are FDA folks who are willing to come talk about clinical trials and the importance of participation and the importance of diversity. And then we can talk, other people in Hep B can come talk, even if it's virtually, about what options are out there right now. And then I think, however, we do keep a list of clinical trials on our website that people can come in, can browse if you wanted to share that information, or even sharing it via your own social media or your own e-newsletters or your own patient lists, letting people know. And there's also, there are clinical trial finders now, so we have one on our website that's powered by a company called Antidote, who does this for free for nonprofits, where you can, they go onto the website, they type in, they answer basically 3 or 4 questions, and it propagates and pops up with clinical trials in their area. So that might be another way, just letting people know that these options are there. And I agree with Yasmin, helping people become comfortable with the idea of clinical trials and really learning about them is probably a first big step.
And it looks like we have one more question. Will you have studies on how COVID-19 vaccines have any impact or interference with Hep B drugs?
That's a great question, and we get it daily. So we are, through our helpline, our consult line, we've been getting at least a couple questions a week about this, not only about the impact of Hep B, the impact of COVID on people who have Hep B, but also, can we take the vaccine? Is it safe? What does it mean for me? We reached out to AASLD just this morning and asked them, what I would prefer is for a professional organization of specialists like AASLD, I would prefer for them to come out with some kind of consensus statement or something on the safety of the vaccine and who should get it, who should think, maybe which one they should get. I don't even know what should be in it yet because I haven't seen all the data. But what we're hoping is that the professional hepatologists will come up with some kind of statement that we can then push out to patients, because without seeing the data, it's really hard to know. But yeah, I think we're working on it, and I think I've seen others. I know other organizations are thinking about this as well. So hopefully between all of us, we'll be able to come up with messaging that we can share with our people, our constituents.
Yeah, great.
And
so,
if I may just share one final thought, I would really would like to thank all the patients who shared their stories and participated in the survey and in the interviews, and let us into their close circle of their life and treatment journey with hepatitis B. We really appreciate it. We learned a lot. We learned that there has been, or there's a lot of work that needs to be done to really ensure a smooth cascade of care and continuum of care and provide comprehensive care that they deserve. Please continue to do that. my message for the patients, please continue to do that. For the patient organizations, please encourage your members to always participate and share their story, their insights. It's extremely helpful, and this is the way to reach a common understanding and achieve our goals, and like and provide the best care that they deserve.
Yeah, absolutely. I think that was a good closing thought. And I totally agree. And I think kind of linking together back the storytelling aspect and this more systematic way of documenting experiences, the two really, I think, go together really well, because we see when people engage in one way, they start to become interested in using their voice and participating in other ways. So I've seen we're seeing some crossover between storytellers participating in the surveys and the PFDD, but also people that you have found through the PFDD and the surveys now being interested in telling their story for the Just Be campaign. So I think the more that we're able to encourage people and really emphasize how needed, like how there's still a lack of information directly from patients, and how personal stories are really, I guess, in demand right now with all the different companies and interest in research and drug development. It's whoever, I think it's been really encouraging to see kind of the momentum building when more people speak out about hepatitis B. That's the biggest encourager for other people to speak out too. So, Sherry, did you have any other closing thoughts?
No, thank you.
Okay, so we're going to switch over to our storytelling panel. I want to thank Yasmin and Sherry again. I know there are some questions about the slides too, so those are available in the Documents tab, and the recordings I think will be available for a while on this platform. So thank you again, Sherry and Yasmin. And we're going to transition into our live discussion with 4 of our amazing Just Be storytellers. I'm going to invite them to join us now. We have Wendy, Joe, Alice, and Dwayne. And so the four of them have all participated in a Just Be workshop. Their faces may look very familiar if you have watched all of our videos or have been to previous summits or advocacy days. So they're here to kind of share a little bit more, not just about their personal story and background, but also to kind of reflect on those questions about how do we get more patients to engage in providing their input on what they want to see in future treatments, how clinical trials should be run, and all of that. So just to start us off, I'm going to go around and ask each person to spend a couple of minutes just introducing yourself and your connection to Hep B. So I think I'll start with Alice.
Hi, everyone. I'm from Sacramento. I've been involved with Hepatitis B Foundation since January 2018, when I was accepted as a storyteller. My background experience, and I'm a registered nurse, and I'm also a public health nurse. So I worked for the state for 26 years before I retired 2 years ago. So now I'm free to do anything I want. And so for my tenure with the state for the 26 years, I have spent most of my time with the refugees health and also with the Medicaid populations. And so in those years, I learned a lot regarding how to do different programs, the health program for people to access, for the especially the refugee health, for the newly arriving refugees, to the California. And there were, at that time, 14 health counties being administered the health assessment and the health care services for refugees. And at that time is the wave of the Hmong refugees and also the Vietnamese refugees. And then in the later 90s. There was the Russian and the Somalia and the Ethiopian. So I'm kind of like, it's my kind of turning point of my professional to deal with the refugees, for the cultural and linguistic aspect of it. And then later on, I spent 14 years in the home and community-based program for the state. So I'm the person that I always like outdoor. And when I go outdoor, my heart blooms when I see all the nature, the flowers, the mountain. So hiking is the main activity for me, for the last 10 years. And then for me, being as a hepatitis B chronic carrier, probably if you have the chance to look at the happy story. So I really definitely advocate for the mother-to-child transmission, how to prevent it. So I focus on that for the mother-to-child transmission in the kind of like the late 1990s to 2000. And then until then, and then I kind of add on to the promoting the vaccination and also the testing for adult, because it is very needed too for a lot of adult being lack of immunization and their lack of knowledge about the hepatitis B. And so I think that's, my life in a nutshell. Thank you.
Thank you, Alice. Joe, would you like to go next?
Yeah, and I'm going to read my introduction, but first I have to say it's a privilege to be a part of the summit, and I'm afraid people are going to think I stole some of Alice's introduction, but here goes. I'm a retired landscaper living in Santa Rosa, California, with Wayne, my husband and partner, going on 16 years. We share a love of gardening and nature, and we love exploring the coastal bluffs, redwoods, and oak woodlands of Sonoma County. And yes, like Alice, nature and hiking are my solace and are so very healing, especially these days. We're committed, Wayne and I are committed to the natural environment, and for several years we've monitored rare wildflowers in our area. While I dream of a quiet retirement, I'm a reluctant activist on issues like climate change, social justice, and recently voting rights. Climate change has impacted our lives here severely. Since 2017, we've endured ever greater wildfire disasters, and we've had to evacuate twice in the last 3 years because of fire approaching our neighborhood. My life with viral hepatitis began with contracting hepatitis B in the 1970s. In the 90s, I was diagnosed with hepatitis Delta. From 2013 to 2019, I made over 70 round trips to Bethesda, Maryland as a patient in the Iger NIH lonafarnib trials to treat hepatitis Delta. In December 2018, I was possibly the first patient to reach undetectable hepatitis Delta levels. Unfortunately, I could no longer tolerate the lambda interferon aspect of the trial, and my doctor stopped all the trial drugs. Cut to the present, my liver is functioning more or less normally. My HBV levels are very low, and my HDV levels is low but slowly increasing. In 2019, while doing research for myself about viral hepatitis, I had the good fortune to find the Hepatitis B Foundation. The Just B Storytelling Project really appealed to me. I'm so proud of the video I made incorporating many important aspects of my life as a gay man, a nature lover, photographer, and as a citizen scientist. The Storytelling Project has vastly improved my humble efforts to educate my loved ones and my community concerning hepatitis B, Delta, and how to prevent infections. Since January of this year, I have consulted with biotech companies and I participated in several hepatitis B panels and conferences. I've even had the ear of the FDA, and that's all thanks to the Hepatitis B Foundation.
Thank you so much, Joe. Yeah, I know that you have been very active this year, even virtually. So I will ask Wendy next to introduce herself.
Hi, my name is Wendy, and I am from Vancouver, British Columbia. I am a retired physical therapist. I enjoyed my job, but I decided to retire early in order to best utilize the limited energy that I had. So instead, I ride my bike about 30 miles almost every day when it's not raining. And in the summer, I'm also busy in my garden, just like Joe. I'm also quite active in my church, which has been a great community for me, and my faith has given me quite a bit of comfort as I've battled with different health issues. I found out I had hepatitis B in university and that I had acquired it from my mom at birth. I did not take it seriously at that time because I didn't know much about it. This was before the internet. I just made sure that my fiance was protected, and I was careful with my blood since I knew it was infectious. Then, in 1999, my mom was diagnosed with liver cancer, and she passed away soon after that. This was a real wake-up call for me. I decided I had to take this much more seriously. So since then, I've been closely monitored and followed by hepatologists. I try to make healthy lifestyle choices, and of course, I avoid drinking alcohol. However, other than struggling with fatigue, I was able to live a fairly normal life and was not placed on medication, which sometimes worried me because I thought, oh, it's going to put me at a higher risk of getting liver cancer if I'm not treated. Then recently, I started taking Vemilide due to elevated liver enzymes and unfortunately developed an allergic reaction to it. I am now dealing with the uncomfortable side effects of skin rashes every night. As a result, my specialist said I could take the pill every other day, even though it's supposed to be a daily dose. So without a consistent dose of medication, I could be damaging my liver. But the side effects are also very unpleasant. It's not a great position to be in, so the cure can't come fast enough for me. I became involved with the Hep B Foundation in 2018 as a storyteller, and I have been so impressed by this talented and dedicated group of people who truly advocate for patients with hepatitis B and provide a voice for people with this disease. They've introduced me to patient-focused drug development meetings and have allowed me to share my story in different forums. I believe it's important to raise awareness of this disease and to talk about how those of us who have it are affected. So I hope you enjoy the session today. Thank you.
Thank you so much, Wendy. And last but not least, Dwayne, could you tell us a little bit about yourself and your story?
A little bit about my story. I was diagnosed as a child around 1986, so I've been dealing with it. It was early in 1986, so probably about 35 years almost now. I contracted Hep B through a blood transfusion, as they weren't testing for Hep B when they were giving the blood back then. And I, suffered an injury that led to me getting that blood transfusion. In the early 90s, I had a severe bout, along with some other health issues that put me in the hospital when I was a teen. Gratefully, I was able to recover from that. And later on, I just went on like normal because it was it always was in the back of my mind, but I wasn't really showing any symptoms, really had no effect. So, and there was a lot of stigma, especially when I was going through school, So when I got out of school, primary school, high school, I basically lied to myself. I told myself I didn't have it, and just pretty much lived, whatever way I wanted to live at that time, and did some risky things, risky stuff. Fast forward to 2015 or 2016, somewhere around there, I end up, I'm married at this time. I end up getting pretty sick one night, and was taken to the hospital. They, of course, ran some tests, and, I let them know I had Hep B. They ran some tests to find out the elevations and stuff of that nature, viral loads and stuff like that, and I was really high. I was able to recover, but I still didn't want to go to a doctor's. If it wasn't for my wife, virtually putting her foot down saying, you need to go to doctors. So anyway, I started going to the doctor, a specialist, in 2018 in Tulsa, Oklahoma, and was end up after a few tests, a CAT scan, a fibro scan, and a few other things, I ended up being put on Entecavir. So I ended up being put on Entecavir. At that time, I really wanted to find out a lot more information, because the information I knew, I had a feeling was pretty much out of date, what I was told in the early 90s. So I started doing a lot of research online. I came across the Hepatitis B Foundation. And during that time, I saw an application. This was 2018. Of course, the cutoff for the Just V story had already ended, but I said, okay, I'm going to submit it anyway. And I submitted it, and it was, Rhea actually contacted me sometime in early 2019. I think it was, that asked me to come. At this time, I was in the transition of moving back east, back home. And I said, that'd be great. And I thought I was going to originally make it out to California from Oklahoma, but we ended up buying our place like a few weeks before. And I had to contact Rhea, say, hey, you need, I'm going to be traveling from South Georgia. So now I reside in South Georgia. Since that time, since I did my story in 2019, I think it was either May or June of 2019, I've been really advocating in my community, because I'm from a really rural area. To give you an example how rural area I'm in, the city I am in has less than 500 population. The county I reside in has less than 10,000 population. So a lot of farmers, a lot of stuff like that around here. And my nearest grocery store is 20 miles. So I have to travel 3.5 hours to go to a specialist in Atlanta, Georgia, which is 3.5 hours north of me. And I go every 6 months. Well, when the pandemic happened, I end up doing, back in July, I end up doing my thing virtually. But no matter what the pandemic's doing this time, there's a couple things I need to get done when I go up. So I have to go in January back to Emory. So, but yeah, the COVID concerns me, because I have right now, I have a small child. I don't necessarily know a lot of information. I know it, with people with underlying conditions, it generally, if you catch it, it will, you're in a higher risk rate. So I try to maintain social distance. Of course, it's pretty easy where I'm at. Not a whole lot of people. But there's still cases in my area. So, but I got kind of off track there. Since I did Just V Storytelling, I tried to, because there's a lot of doctors in my area. They know a lot about Hep C. A lot. They know how to treat it. Of course, they have a drug for it to treat it. What have you not. To give you an example, when I left from Tulsa that came to Georgia, my primary doctor referred me to a GI out here in Macon. So I go up to the appointment, and the GI tell me, it says, I thought you had Hep C. I can't, I have no idea how to treat Hep B. And so I thanked him for his honesty, but that kind of triggered me. Maybe, my primary doctors and, where I'm at in the smaller communities don't know much. So I started to get a lot of literature, everything I could get. And matter of fact, my primary didn't really know too much either. And so I brought in a lot of literature that I obtained either through the CDC, at the summit last year, a lot of different information. And then I just started going around to local doctors, asking them if I can just, give them the information. And if not, if I can leave some pamphlets in their lobby so other people, may have questions about it, because I believe there might be a lot of adults that never been tested for it, never been vaccinated for it. And I'm just trying to get out there in my community, be aware of your status. I mean, it's no big deal to go get tested, be aware of your status, because, this disease is a silent killer. A lot of people don't exhibit signs or symptoms until it's, really too late. So that's what I've been doing. And I've been doing a lot of social media type stuff, different groups I'm involved with, like Hep B survivors and a few different things. A lot of questions I can't answer, but that's pretty much my story. So roundabout way, if you want to know more about the background of my story, you can always watch me on YouTube.
We'll be asking more questions, Dwayne.
Okay.
So do you want me to ask the questions now, Rhea?
Yeah,
so
thank you guys for introducing yourselves. Go ahead, Wendy.
Okay, so everyone here, what motivated you to speak and share your Hep B story? Did you have to overcome any barriers or fears in order to do so?
Okay.
Okay, go ahead, Joe.
Alice?
Okay, for me. So the motivation for me to speak up about my Hep B status is kind of to me, take me a long time, 20 years, because I've been advocating for Hep B mother-to-child transmission, for the prevention, but I never exposed or disclosed my health status about I'm a chronic Hep B carrier because of the stigma, and that is a taboo, that being has in a traditional Chinese family. But finally, by the time when I was in the workshop, in the storytelling workshop, in the circle time, I was very impressed with how they conduct the circle time to allow me to open up and share my information in a group of people I feel comfortable. I feel I can let go whatever my fear, because they are there, with me. And so that was the first time I ever, other than with my family, to telling everybody who I am, being a chronic carrier. And but one thing I want to say is being as a storyteller, when I registered for the workshop, I really don't know exactly how things will go. I'm thinking about very kind of like a nail focus. Okay, you want to have a storytelling for the video, and then it's done, it's over, and then that's it. So, but it's very interesting after that, and that really opened door for me to allow myself to reach out to the populations even much broader and at different level. So, and then since then, I feel like now is the time for me to tackle all community at all levels to let people know. And so that will be a more effective way and, efficient way to promote the Hep B testing and vaccination and all kind of prevention. And I think that is really a booster for me, being part of the Hep B Foundation member. And then with the Hep B United, I learned so much. And that is further motivate me to do more.
Thank you, Alice. And Joe, you want to say something?
Yeah, maybe 20 years ago, I had a dear friend who almost died of HIV, and then the new drugs came along, and it was like he was reborn, and he was an incredibly dynamic and creative person who went on to do great things. But sadly, his doctors, it never occurred to them to test him for hepatitis B or any viral hepatitis. And by the time they understood what was making him sick, he was too far gone, and he died of cirrhosis. And if only I'd known what he was going through, because I was already taking effective drugs for hepatitis B, and I think I could have made a difference for him. He might still be with us today. But in the gay community and in the community of sexually active young adults, not just gay, people are focused on HIV, AIDS. And, we've got excellent preventative protocols like PrEP, but people are still not thinking of other serious illnesses like hepatitis B. And of course, very few people know about hepatitis Delta. So my motivation has been not, wanting people to understand the simple things you can do to prevent yet another serious disease, and not wanting people to go through what I'm going through, and maybe all they need is a B vaccination. So that was a big part of my motivation. I also have wanted my loved ones to understand what I'm going through, and to be educated, because I don't know, it makes me angry when people say, well, I don't want to tell my family because, I don't want to upset them. But then all of a sudden, maybe you need a liver transplant, and then you finally have to tell them. And maybe it's better to educate the people you know early on rather than waiting until things are dire.
Great. Good points, Alice and Joe. I agree. For myself, I remember when I was approached about doing the storyteller, I was still working at the time in healthcare. And interesting enough, even some of my coworkers, when a patient came in with hepatitis B, they said, oh, do we have to gown and glove? And I went, no, you don't need that protection. It's not that infectious. You've all had the Hep B vaccine. You'll be okay. But I realized that there was just even there some ignorance within the healthcare profession as in terms of how it's transmitted. So I was a little bit fearful of being a storyteller until I retired. And because I didn't really want to freak out all my coworkers that I had hepatitis B, because I didn't exactly announce that to everybody, because I knew that my risk of transmitting was super low since I didn't deal with bodily fluids. So yeah, it was a bit fearful for me to do that, but I also thought it was important because I think that we need to have a voice. We need to be able to go out there and say, hey, we have this disease. It's got its consequences, and just be aware, to have awareness, so that hopefully that will help people to realize that it exists and that we really want to find a cure someday. So the next question I want to ask is, again, with Joe and Alice. We all provided testimony for the Hep B patient-focused drug development meeting in June that Cherry just presented on. What did you think of that process and overall experience? Do you feel that was an effective way to highlight the needs and preferences of people living with Hep B? What other actions or next steps do you hope to see from drug companies are from federal agencies like NIH and FDA as they continue working to develop a cure.
Okay. Yeah, it was a great experience. And, you know, it felt so good to be able to share my experience, having been in 6 years of a clinical trial. And while you're in a clinical trial, you know, things come up and you don't always get to say, hey, maybe we could do things differently. Or one thing I had hoped for, and I was so glad to be able to share this with researchers and with the FDA, was, you know, having had to go across country for 70 round trips. There were times where that was really hard, when I was feeling ill or when I was reacting to the trial drugs. There were times I just didn't want to get on a plane. And I had hoped that at least some of my visits and testing could have been done closer to home. In my case, at UCSF or Stanford, which are no more than 2 hours away, and I could go by car, and you know, and I'd like to see more of that. I recognize where patients might have to go to the NIH or to wherever, the Mayo Clinic or wherever the trial is being done. You know, that's a requirement, but we need to find ways to make the whole process easier. And if some of that could have been done locally, that would have really made it immensely easier. And of course, another thing that I got to mention was my hope that for treatments for hepatitis B and Delta that didn't require interferon, because in my case, I wish all I'd had was rashes. And not to make light of what you experienced, but I get enough rashes hiking around here from poison oak and poison ivy. But I mean, it seemed like every week there was a new symptom in my reaction to the interferon. I wound up with hernias, ascites, you know, my liver wasn't functioning right, so all kinds of things went haywire, and I was really frightened for my well-being. And so I say all that to emphasize why I keep bringing up treatments that don't require interferon. And maybe in my case, it was because my liver health was a little too compromised. I don't know, but yeah.
Yeah, I've heard interferon can cause some pretty serious side effects. And Alice, did you have anything to share?
Yeah, for the interferon, I want to tag onto it because by the time I was diagnosed with chronic Hep B, and I heard about the treatment interferon. This is the one that brought to my attention up front. And then I kind of like understand the significant side effect, the adverse effect, you know, of the drug. So that's the kind of put it off on my mind that consider for any treatment at that time. And so by the time, you know, the doctor kept monitoring my viral load, it was low. So kind of like did not suggest any treatment for me. And then, but another advice at that time, you know, was talking about, yeah, maybe you can look at some other drugs, you know, in case, because at that time, you know, I was thinking about, I definitely don't want the progress in the liver, the viral be going up. And so clinical trial was mentioned, by a person. And then at that time, I was looking into clinical trial information because in those days, internet is not accessible. So you have to dig in, literature. We'll go to the library, look for books, to read about anything. The information is very kind of limited. That's what I really kind of like we suggest, the FDA, the federal or the local level to being really get the dissemination of the information for clinical trial accessible, not only through the internet, but also through kind of like the grassroots level that people, if they are not kind of internet savvy, they are not technology savvy, they can still access the information. Because at one of the presentation I did, it's a early part of this year, and then there was a clinical trial talk, a small brief discussion to the medical assistant in one of those FQHC clinic, and then but the information is still very limited, regarding the resource available. And that's what my comment is, a wish, there will be a more comprehensive section to inform not only the patient, but the kind of like the para health professionals, that they will be able to understand what exactly clinical trial meant to everybody and their knowledge. For the PFDD meeting, I think this is very, very impressive because involve a patient to tell them the story about how they feel, other than, from the providers, from the researchers. And so that is a direct message will be conveyed to the FDA. I think this is very powerful because I did have some feedback, from providers, listening to the patient's testimony at the meeting. They were very impressed. Even they themselves, as the, clinical practitioner, they feel like this is something that they need to listen to the story of the patient, how they feel. And then that is definitely move up, the pipeline to go to the federal level to have them to make a decision. And part of it will be based on the patient's experience and the patient's preference. Because so many times, even though I did not take the interferon, but as a nurse, I heard about a lot of patients. They stop, but on their own, because they don't know exactly what is the consequence. They don't know exactly, because especially in the Asian community, taking a pill, for a long term can be very devastating, to their health. And a lot of time they not even inform the doctors about what they would do. They just stop it on their own. And the risk, can be very kind of like the impact can be very severe to their health, based on some of those examples that I learned from other patients.
Okay. All right. Well, thank you, Alice. Yes.
Could I just add one thing? At that meeting, and also a live conference I went to in, I believe it was January, at Vir Bio Pharmaceutical Company, I was amazed. I had never directly talked to researchers other than my own doctor at the NIH, but so many people came up to me and said, "Thank you. We have never actually met a patient." And that's huge. I think it just may, you can have all the knowledge in the world, you can be an expert, but a part of your experience sometime has to be actually interacting with patients, even if you're not treating them, but to have a one-on-one, I think is really important.
Right. Well, I think you almost answered the next question, Joe, that I was going to ask. And this is also to Joe and Dwayne. The three of us participated in focus groups, patient advisory meetings, and other events where we engage directly with pharmaceutical companies. Could you talk about your experiences, both positive and negative, with these types of activities? What suggestions do you have to make the process easier for patient voices to be heard and prioritized? I would like to say that myself, I found that that was an incredibly positive experience to be involved with the pharmaceutical companies, which, I mean, I think a lot of us have this impression that it's big pharma and they don't really care about the people. They just want to make money. But on the other hand, I felt like they were really listening to us, that they wanted to know what our input was and how they could make the studies more effective and more appealing to people. And they really appreciated our input, which I thought was great. I think one of the negatives I found out was that because they probably hadn't had as much interaction with real patients, that some of the ways that they presented the information, as or at least showed us what they planned to present to the patients, I felt didn't really speak to people. And so we gave that feedback that, yeah, this probably people wouldn't understand what you're trying to get across here. And I think that it was good that they had these, though, because I think it was it's a great way of actually engaging people and getting their real input about it. So I think that was definitely a positive and a negative. And did you want to add anything to that, Dwayne?
Yeah, there's not much I can follow with that. I experienced the same type of similar when the pharmaceutical company I dealt with back in January of this year. I was glad that I was able to go up there, put my input in and stuff. But like it was kind of like a negative and positive, because the way they wanted to go about it, I didn't think it was, really kind of disconnect. And we also, in our focus group, also brought that back up to that pharmaceutical company. But I'm glad they are interested in listening to patients and how to further, try. The more info you can get from patients, the better you can help them, not only with drugs, but, because every patient's circumstance might be different, So, and I learned that just by watching, the Just Be stories and stuff of various different patients like Joe and the ones prior to us and stuff like that, your story and, Alice, I haven't quite got through all of them yet, but I've watched a lot of them prior to, our group. So on the Just Be, but yeah, I before that, I had the same feeling. I thought that, they're this big pharma, they don't care. Until I went up and I actually spoke with these people, and I see that they were really interested in what we thought and how to go about it, and what they could do, that might be work, that might be more beneficial to the patient. So that was really great, and that on that end. But it's kind of like I left with kind of the feeling, well, I think our group was maybe 10, 12 people, maybe 15. I can't really remember, but I left with the feeling, I says, I hope they honestly take a look at what we said. Now, whether they're going to or not, I don't know. I didn't really get any feedback on that end, but I was very hopeful that they, took the time and the investment to bring us up. So if they were willing to do that, maybe they were willing to actually listen further to us. So.
Okay, thank you, Dwayne. So, Joe, did you want to add anything else before I hand it back to Rhea?
I do. Yeah. I participated in consulting with 3 pharmaceutical companies, and one was really a private phone call with Eiger Pharmaceuticals, who developed lonafarnib and were partners with the NIH. And that was really cool to, after everything was done, to talk to them kind of one-on-one in a conference call. And then the experience with Vir Biotechnology in San Francisco, that was great too. They had, most of the people who worked there attended our session, and that included everyone from the janitor to the scientist to the CEO. And I mean, one of my best conversations was with the janitor and the delivery boy. My sense was that they were all really with the program. They all were really charged up by what they were trying to do. Then there was another company who I won't name, who I did the most, spent the most time with, and that was helping to develop a patient portal for a future hepatitis B clinical trial. And that got really bogged down. And a big part of the problem was that the people conducting the, this trial interface that we were supposed to work on and give our input about, they didn't understand that we're not all deep in the world of internet conferences, technological speak, and their communications were poorly written. We struggled to understand what the heck they were talking about, what they wanted from us. And I found it very frustrating. My blood pressure probably went up a few points while I was working with them. I have to say that the Hepatitis B Foundation kind of came to my aid. We were paid for that, which was really nice because by then we had COVID and I was not working very much. But the Hepatitis B Foundation, Ria and Sierra in particular, basically said you need to pay your patient consultants for all of their time, not just the time you estimated. And that made the pain a little less severe.
Okay, thank you, Joe. And Rhea, you had some other questions that were from the audience?
Yeah, and actually one of them I can just address really quick since Joe wrapped up with that, because one person